Good morning, all. A gentle reminder to kindly keep your audio mute during sessions. Welcome you all to the third session of Rapid Review Program for Undergraduates, Exam Tips 2021, organized by Department of Oral Pathology and Microbiology, Annoor Dental College and Hospital, Muvatupuzha. Myself, Dr. Cyst and Dr. Anjana will be your host for the day. As a famous quote goes by, success is where preparation meets opportunity. So you students have been blessed with golden opportunity of this experiential learning from eminent faculties since 3 weeks. We, Annoor Dental College and Hospital, are honored to provide a platform to share knowledge in the best possible way we can. Because we believe today is the opportunity to build the tomorrow you want. This belief of Annoorians paved the way for numerous accolades in the yesteryears, which include College of the Year 2019 by the Higher Education Review magazine, 22nd Best Private Dental College in India by prestigious The Week Hansa Survey 2020, and of recently, we have been crowned with the glory of highest grade of NAC accreditation B++ for a standalone dental institution in India. Let's have a glance at the proud journey of Annoor so far.
History has proven that those who dare to imagine the impossible are the ones who break all the human limitations.
यस्यां समुद्र उत सिन्धुरावो यस्यामन्नं पृष्ठयः सम्बभूव यस्यामिदं जिन्वति प्राणदेय सा नो भूमिः पूर्वमेव दधातु
Moving on to the first session of the day. If you have any doubts, please post it in the chat box. We'll be getting back to you later through WhatsApp group. Now introducing the speaker, Professor Dr. S. Sunil, currently working as Professor and Head, Department of Oral and Maxillofacial Pathology, Pushpagiri College of Dental Sciences, Tiruvalla. He has done BDS and MDS from Government Dental College, Trivandrum. He is a recognized PhD guide in Kuhas University and doctoral committee member for VIT University. He has been in the organizing panel for various state and national conferences. He marks his presence in the editorial board and reviewer board for various scientific journals. Currently, he is the President-elect KSOMP and Honorable Secretary, O Kerala Chapter. He has numerous publications to his credit also. Wholeheartedly, we welcome you, sir.
A very good morning, all of you. And thank you, Doctor, for your kind introduction. First of all, let me congratulate the Annoor Dental College team for organizing this novel program, Rapid Exam Review for the undergraduates oral pathology students. I'm sure that our dear delegates are enriched with the last 2 days lectures and reviews by the expert panel. My topic in this rapid review program is the odontogenic cyst. That is a very important topic. Questions are sure to be asked from this topic. It can be an essay question, it can be a short essay question, or even short notes can be asked from this topic. So don't forget to learn this topic. Be thorough with the topic. You can score minimum 10 to 15 marks out of 70-mark question. To start with, we should know what is a cyst. You know, cyst is more common in the orofacial region. The definition of cyst is very important. You should by heart it. The definition is given by Kramer in 1974. A cyst is defined as a pathological cavity having fluid, semi-solid, or gaseous content and is not created by the accumulation of pus and frequently but not always lined by the epithelium. So, a cyst is a pathological cavity having fluid, semi-solid, or gaseous content, not created by accumulation of pus and frequently but not always lined by epithelium. That means there are cysts with epithelial lining, and they are called the true cysts, and those cysts which are not lined by epithelium are called the false or pseudocysts. You see, this is a tennis ball, no? It's a section cut part of the tennis ball. I always, when I teach my students, always advise them to remember this picture because this depicts the pictorial of a cyst. It has got a connective tissue capsule, which is the yellow covering of the ball. That is the connective tissue capsule of the cyst. The inner part is the epithelial lining. The rubber part, the innermost, is the lumen of the cyst. That's a big picture that gets you to take that picture into your mind. This is the cyst. Cysts are very common in the orofacial region. Now, classification of cysts is very important. When the question comes for an essay question, the first part of the question could be either a definition of a cyst or classification of cysts. Cysts of the orofacial region can be classified as odontogenic cyst. They could be non-odontogenic cyst, and there are miscellaneous types of cysts. There are a lot of classifications in the textbook. This is a classification which I have taken from the Schaefer's textbook of oral and maxillofacial pathology. Cysts of the orofacial region may be odontogenic, non-odontogenic, and miscellaneous. I am restricting the discussion on odontogenic cysts only. So we will discuss the classification of odontogenic cysts. Odontogenic cyst means those cysts which are derived from the epithelium associated with the dental apparatus. Odontogenic cysts are cysts arising from the dental apparatus. Accordingly, the odontogenic cysts could be of two types. They could be either developmental or they could be inflammatory type. The odontogenic cyst classification, they could be developmental or inflammatory. Under developmental type of odontogenic cysts, they include the intraosseous types and the extraosseous types. And the intraosseous odontogenic developmental cysts include the dentigerous cyst, odontogenic keratocyst, the lateral periodontal cyst, and the glandular odontogenic cyst. The extraosseous form of developmental odontogenic cyst include eruption cyst, gingival cyst of newborn and adults. Those are the developmental odontogenic cysts. The second group is the inflammatory type of odontogenic cyst, under which comes the most common type of cyst, the periapical cyst, then the residual cyst, the paradental cyst, and buccal bifurcation cyst. So classification is very important. Odontogenic cysts may be classified under two headings, that either developmental or inflammatory. Under developmental comes the dentigerous cyst, OKC, lateral periodontal cyst, and glandular odontogenic cyst, eruption cyst, and gingival cyst of newborn and adult. The inflammatory cysts include the radicular or the periapical cyst, the residual cyst, paradental cyst, and buccal bifurcation cyst. You should remember the names of the cyst, the assailer. You have to enumerate these cysts. They could be either developmental or inflammatory. Remember, either definition and classification or classification may be asked as the first part of the essay question. I am skipping the non-odontogenic cyst and the miscellaneous type of cyst. Now, odontogenic cyst, we have classified, we have enumerated the cyst, and based on the cell of origin, they could be classified as those which are arising from the epithelial rest of molasses, and those arising from the reduced enamel epithelium, and those arising from the dental lamina. Those example for those cysts, odontogenic cysts arising from the cell rest of molasses include the periapical and residual cyst. Cysts arising from the reduced enamel epithelium include the dentigerous and eruption cyst. And those cysts arising from the dental lamina include odontogenic keratocyst, gingival cyst of newborn and adult, and lateral periodontal cyst. That is the classification. Okay, now we'll see a few important lesions, important cysts which are sure to be asked for the exam. First, we will see the developmental cyst, and under which the most common type of developmental odontogenic cyst is the dentigerous cyst. It's also known as the follicular cyst. Dentigerous cyst or follicular cyst, that is the most common type of developmental type of dentigerous cyst. A dentigerous cyst is a cyst that surrounds the crown of an impacted tooth, which is caused by the accumulation of fluid between the reduced enamel epithelium and the enamel surface, which results in a cyst in which the crown is located within the lumen. Okay, that's a description of a dentigerous cyst. It is an odontogenic cyst surrounding the crown of an impacted tooth caused by accumulation of fluid between the reduced enamel epithelium and the enamel surface, resulting in a cyst in which the crown is located within the lumen. As I said, it is the most common type of developmental odontogenic cyst. Approximately, it constitutes the 20% of all odontogenic cysts. Now we'll see the clinical features of dentigerous cyst. Clinically, it is always associated initially with the crown of an impacted, embedded, or unerupted tooth, or it may enclose an odontome or a supernumerary tooth. A dentigerous cyst always are associated, at least initially, with the crown of an impacted, embedded, unerupted, or it will tooth or crown or enclose an odontoma or a supernumerary tooth. Regarding the site of occurrence, it is usually occurring in the mandibular and maxillary third molar region, or it is usually associated with the maxillary canine region. Okay, site is mandibular third molar, maxillary third molar, and maxillary canine region. And age of incidence is more commonly, it affects the second and third decade of life. There is a slight male predilection. The male to female ratio is approximately 3:2. Most dentigerous cysts are occurring as a solitary lesion or a single lesion. But there are cases reported where bilateral and multiple cysts occur. The bilateral or multiple cysts are usually associated with syndromes. The syndromes which you have learned that include the cleidocranial dysplasia and Madotox Lamis syndrome. These are examples for syndromes where multiple dentigerous cysts could be seen. Now, usually, clinically, the dentigerous cysts are non-aggressive. They may not produce much symptoms. But when these lesions become aggressive, these are capable of producing buccal and lingual cortical expansion. There could be expansion of bone, which could result in facial asymmetry. There could be displacement of the teeth. There could be root resorption of the adjacent teeth, and pain may be there. These are all possible when the dentigerous cysts become aggressive. Now, after clinical features, an important feature is the radiographic findings. Radiographically, a dentigerous cyst usually shows a unilocular radiolucent area, which is associated with the crown of an impacted or unerupted tooth. It shows a unilocular radiolucency around an unerupted tooth crown. Usually, the radiolucency is well defined, and often a sclerotic border may be seen. In a dentigerous cyst, a unilocular radiolucency with a sclerotic border is typical. But when the cyst gets infected, the border becomes ill-defined. Okay. Now, when you see a radiolucency around an unerupted or impacted tooth crown, we should be able to differentiate an enlarged follicle from a dentigerous cyst. It is depicted that a normal follicular space is about 3 to 4 millimeter in diameter. A dentigerous cyst should be suspected when this space is more than 5 millimeter. When you see a radiolucency, see the OPG given. When you see a radiolucency around a tooth unerupted crown, if the radiolucency is beyond 5, which is more than 5 millimeter, we should suspect a dentigerous cyst. Now, theoretically, the radiographic variants have been reported. Dentigerous cyst could be of 3 types. One is the central variety, the second type is the lateral variety, and the third type is a circumferential type. The first one is the central variety. See the right top picture. Here, the crown is enveloped symmetrically and the crown projects into the cyst. That is the central variety of dentigerous cyst. The second type, the lateral type, is dentigerous cyst here due to dilatation of the follicle on one aspect of the crown. There is dilatation of follicle on one aspect of the crown. The cyst will grow laterally along the crown and root and partially surrounds the crown. That is the lateral type, the second picture. The lateral type is mostly seen in impacted, especially mesioangular type of impaction of third molar tooth. The third type is the circumferential type, and here results when the follicle expands in a manner in which the entire tooth appears to be enveloped by the cyst. The third picture, the lowermost picture, that is the circumferential type. This is circumferentially envelop the tooth. When the cyst becomes large, it can give an impression of a multilocular process. This is because of the persistence of bony trabeculae within the radiolucency. Okay, I said usually the cyst is a solitary lesion producing a unilocular radiolucency. When the dentigerous cyst becomes very large, when it expands, it can give an impression of a multilocular radiolucency because of the persistence of trabeculae within the radiolucency. That's a radiographic finding. We should differentiate some other lesions which are commonly occurring in these sites and which resemble dentigerous cyst. And these lesions include odontogenic keratocyst, unilocular ameloblastoma, and many odontogenic and non-odontogenic tumors with a similar radiolucency should be excluded before coming to conclusion or diagnosis of a dentigerous cyst. Next is the histopathologic features of dentigerous cyst. Again, it's very important. It could be asked separately as a short note also. Histopathology of dentigerous cyst. Histopathology varies depending whether the dentigerous cyst is inflamed or non-inflamed. As I have shown the tennis ball picture, histopathologically it has got a connective tissue capsule, it has an epithelial lining, and it has a lumen. Usually in a non-inflamed cyst, a dentigerous cyst has got a fibrous connective tissue wall and which is loosely arranged. And it contains considerable glycosaminoglycan ground substance. And within the connective tissue capsule, small islands of odontogenic epithelial rest could be seen. Okay, that's about the connective tissue capsule. And this connective tissue capsule are lined by 2 to 4 layers of non-keratinized stratified squamous epithelium. The epithelial lining typically consists of 2 to 4 layers of non-keratinized stratified squamous epithelium. And the epithelium connective tissue junction is flat. That is the typical cystic lining, 2 to 4 layers of epithelial cell lining a loosely arranged connective tissue capsule, and the epithelial connective tissue junction is flat. When there is inflammation of the dentigerous cyst, now the fibrous connective tissue wall becomes more collagenized with a variable amount of chronic inflammatory cell infiltration. And the 2 to 4 layers of epithelium gets hyperplastic and pretty ridges formation may be seen, and even the non-keratinized epithelium starts keratinizing. So those are the histopathologic features of dentigerous cyst. For the undergraduate exam, this picture is very typical. You should be able to draw this diagram and the question is asked. It has got a connective tissue capsule which has some fibers, some odontogenic islands are seen in the connective tissue capsule, and this is lined by a ribbon-like epithelium, 2 to 4 layers of non-keratinized stratified squamous epithelium. That is the histopathologic feature, a diagram for the dentigerous cyst. Very important. Learn this diagram. It could be asked for the practical exam spotting, or it could be asked the theory question as well. Now, the epithelial lining of the dentigerous cyst may contain a few cells that include mucus secreting cells in the epithelial lining. There could be respiratory epithelial lining when the cyst is associated with the maxillary canine or molar region. There could be sebaceous cells in the connective tissue wall. There could be lymphoid follicles with germinal centers. Okay. Then, when another important body which is seen in the histopathology is when the cyst gets inflamed or infected, Rushton bodies could be identified in dentigerous cyst as well, in the epithelium. Rushton bodies is a short note question. It could be asked for a 3-mark question. Rushton bodies are tiny, linear or arc-shaped, refractory and non-birefringent hyaline bodies with variable stainability, uncertain origin, questionable nature, and unknown significance. And they are seen in the epithelium of a dentigerous cyst. Rushton bodies are tiny, linear, arc-shaped hyaline bodies. They are amorphous in structure. They are eosinophilic bodies, brittle in nature. They are refractory, non-birefringent. The stainability is different. And regarding the origin, it is uncertain origin, but supposed to be one school of thought is that it originates from the blood. Hematogenous origin has been suggested. That could be asked as a short note. Rushton bodies are linear, arc-shaped, eosinophilic hyaline bodies seen on the epithelium of infected cyst. It could be seen in granuloma, infected peripheral granuloma, radiographic cyst, or any odontogenic or non-odontogenic cysts which are inflamed. Now, next part is the lumen of the cyst. The content of the cyst lumen is that the dentigerous cyst has a thin, watery yellow fluid and occasionally blood tinged. That is the histopathology. It has a connective tissue capsule, it has an epithelial lining, it has a lumen. Now, coming to treatment of dentigerous cyst. When the cyst is very small, the smaller lesions can be surgically enucleated. A larger cyst needs marsupialization. This is we have to decompress the cyst, we have to reduce the size of the bone defect. Later, after reduction size, we're going for the surgical excision. The two treatments, enucleation and marsupialization. Marsupialization and enucleation, that is part 1 operation and part 2 operation. Now, before we end the dentigerous cyst, we should see the potential complications that also occur, which can occur from a dentigerous cyst. There are 3 main complications expected. One is the development of ameloblastoma. The second one is the development of squamous cell carcinoma. And third one is the development of mucoepidermoid carcinoma. Ameloblastoma can occur either from the epithelial lining cells or it could arise from the odontogenic cell rest in the connective tissue capsule. Squamous cell carcinoma may arise from, similarly, either from the epithelial lining or it could arise from the odontogenic islands. Then mucoepidermoid carcinoma, I said there are a few mucus cells present. There could be mucus cells present in the epithelial lining. From that, mucoepidermoid carcinoma can occur. So these are the complications which can occur in dentigerous cyst. So that is very important. Dentigerous cyst, it could be asked as an essay question. So you have to give a description, you have to describe the clinical features, radiographic features, histopathologic features, treatment and complications of dentigerous cyst. Can be a long essay, could be asked as a short essay, short note. Definition of cyst or classification of cyst should be there. It is asked for an essay. Then dentigerous cyst clinical features, radiographic features, histopathologic features, treatment. The next lesion, which is important for your examination, is odontogenic keratocyst. This is another developmental odontogenic cyst. odontogenic keratocyst that is described by Philipson in 1956. Now, the para-keratinized odontogenic keratocyst and the orthokeratinized variants are supposed to be two different types of OKC. This is an aggressive type of developmental odontogenic cysts which are derived from the cysts of dental lamina. Coming to clinical features of odontogenic keratocyst, the more common type we are discussing is a parakeratinized type of OKC. The mandibular, molar, and ramus area is more commonly affected than the maxilla. Usually, they are asymptomatic due to linear growth pattern. The Dentigerous cyst and other cysts grow in a buccolingual direction so that the expansion may be noticed much earlier, whereas in OKC, due to its linear anteroposterior growth pattern, the expansion may be delayed. They become symptomatic when it occurs in maxilla or due to proximity of the sinus. Multiple OKC in children are associated with nevoid basal cell carcinoma syndrome. Nevoid basal cell carcinoma syndrome. In that syndrome, multiple OKCs are reported. Usually, OKC is solitary, but multiple lesions are usually associated with some syndromes. Coming to radiographic finding, it is usually they are unilocular, but larger lesions may produce multilocular radiolucency. Sometimes they will mimic ameloblastoma, the most common, or the more clinically relevant odontogenic tumor. When associated with an impacted tooth, it can resemble a dentigerous cyst. A unilocular radiolucency or a larger radiolucency associated with the crown of an impacted tooth. In the dentigerous cyst also, we said that OKC should be considered in the differential diagnosis. See this radiograph, you can see a large radiolucency, in fact, multilocular, extending from 3-4 region to 3-8 region. Usually, it produces displacement of the adjacent tooth and rarely produces a resorption of the tooth. Coming to histopathologic features, histopathologically, the odontogenic keratocyst could be parakeratinized, it could be orthokeratinized, or in sometimes both parakeratinization and orthokeratinization may be noticed. The majority of the cysts are usually parakeratinized. When you discuss the histopathology, it's very important. It can be asked as a short note, can be a 5-mark question. Histopathology is very important. It has got a parakeratinized epithelial lining, which appears to be corrugated, rippled, or wrinkled. The epithelium is of uniform thickness. It has got 6 to 10 cell layers. The epithelial lining of odontogenic keratocyst. It is of uniform thickness of 6 to 10 cell layers, and the surface is parakeratinized, is corrugated or rippled or wrinkled appearance. And the epithelium has got a palisaded and polarized basal cells, and with a classic picket fence of tombstone appearance. The basal epithelial cells are palisaded and polarized with picket fence and tombstone appearance. A space actually exists between the epithelium and connective tissue. The connective tissue, epithelial connective tissue junction is flat and friable. Because of that, it gets detached from the underlying connective tissue capsule. And the connective tissue capsule is usually fibrous and loose, and it contains small islands of odontogenic epithelium. And the lumen of the odontogenic cyst contains a thin straw-colored fluid, or it could be thick, creamy material. Lumen contains a straw-colored fluid or thick, creamy material. The cystic fluid contains a very low content of soluble protein. The protein content in OKC is very low. So that's histopathology. It has got a connective tissue capsule and an epithelial lining. The connective tissue capsule is collagenous or it's fibrous with odontogenic islands present, and the epithelial lining is typically a uniform thickness of epithelium containing 6 to 10 cell layers of cell epithelium. The surface is parakeratinized, which could be corrugated, rippled, or wrinkled. It has got palisaded and polarized basal cells with a characteristic picket fence and tombstone appearance. The epithelial connective junction is flat and it is friable, so that it gets detached from the connective tissue capsule. The lumen contains a strong-colored fluid, thick, creamy material, and the protein-soluble protein content is very low. Histopathology diagram is very important. There's a typical OKC. See the uniform thickness of epithelium is 6 to 10 cell layers. Usually gets detached from the underlying connective tissue, and that is the typical histopathology of OKC, odontogenic keratocyst. See, there is a surface parakeratinized corrugation, palisading basal layer of cells. Almost a sure question again to be asked. The diagram of OKC could be asked in practical spotters, or it could be in the theory question also. Coming to treatment and prognosis is again larger lesions treated by marsupialization, smaller lesions by enucleation and primary closure, enucleation and packing given. Compared to other odontogenic cysts, it has got high recurrence rate. As I said in the first point, it has an aggressive type of odontogenic cyst. The recurrence rate is also very high. So that finishes the second important lesion in this chapter, odontogenic keratocyst. Now we'll just brush up a few more odontogenic cysts. The developmental odontogenic cysts other include the lateral periodontal cyst. As the name suggests, this is occurring on the lateral aspect of the tooth. It occurs as a slow-growing, non-expansile type of developmental odontogenic cyst. It is considered to be the intraosseous variety of gingival cyst of adult. The possible origin include that similar to that of a gingival cyst of adult. It could originate as a dentigerous cyst and then erupt onto the lateral aspect of tooth. It could arise from the cell rest of molasses, or it could arise from the dental lamina. This lateral periodontal cyst. The polycystic variant of the lateral periodontal cyst is also called the botryoid type of odontogenic cyst. Coming to clinical and radiographic findings of lateral periodontal cyst, usually they are asymptomatic, and if it is on the labial aspect, it produces some labial prominence. The mean age of incidence is 50 years. Males are slightly more commonly affected than females. It occurs either in the mandibular incisor region, canine region, or bicuspid area. Radiographically, typically it has got a radiolucency less than 1 centimeter in diameter with a sclerotic border. See the OPG. See the radiolucency on the lateral aspect of canine premolar region. Histopathologically, the lateral periodontal cyst has a connective tissue capsule and an epithelial lining, which is usually non-keratinized with a longer focal thickening, and it may show some glycogen-rich cytoplasm. The epithelial cells show glycogen-rich cytoplasm. The connective tissue near the epithelium is hyalinized. Dental laminar rest can be seen in the connective tissue capsule. Treatment is surgical enucleation. In the differential diagnosis, Ameloblastoma, the portrait type, should consider the ameloblastoma. Then comes some extra-osseous type of developmental odontogenic cyst. In this, the important lesions include the eruption cyst or eruption hematoma. It is actually a soft tissue analog of the dentigerous cyst. We know that a dentigerous cyst occur around the crown of an unerupted tooth within the bone, whereas eruption cyst occur when a tooth is embedded in its eruption within the soft tissues overlying the bone. See, that's a typical clinical picture depicting an eruption cyst. It occurs in children of different ages and occasionally in adults if there is delay in eruption. The primary and permanent dentition affected, usually it occurs anterior to the molars, first molars. Clinically, it produces a smooth swelling over the erupting tooth, either normal in color or bluish. It is usually painless unless infected, and it is soft and fluctuant. The surface trauma will produce blood in the cystic fluid, imparting a bluish or purplish color. Then we call it as eruption hematoma. It being a soft tissue, normally doesn't produce any radiographic finding, but sometimes it may show a soft shadow, no bone involvement except that the dilated and open tip may be seen on the radiograph. That is eruption cyst. Then a dental lamina cyst of newborn and the lamina gingival cyst of adults are important. And the lamina cyst of newborn is keratin-filled structures which are seen on the angular ridges of neonates. It arises in the from the dental lamina, and that will usually resolve without any treatment. Then another term called Epstein pearls. These are the cysts occurring on the mid-palatine raphe. Then another term, Bones nodules. They are occurring at the junction of hard and soft palate. Bones nodules are supposed to be arise from the palatal salivary gland structures. So there's a picture of new cyst, the cyst of newborn, gingival cyst of newborn. Then gingival cyst of adult. Again, this also occurs in the free or attached gingiva, closely resembles a superficial mucosa. It may have the same color as that of the adjacent mucosa. Usual site is mandibular canine region similar to lateral periodontal cyst. It could arise from the dental lamina or heterotrophic collection of glandular tissue. See the picture, it looks like a small mucosal occurring on the mandibular canine region. Usually that is a gingival cyst of adult. So with that, we finish the important lesions from the developmental type of odontogenic cyst. Dentigerous cyst, OKZ. These are very important, almost a sure question expected. Next, we will see the inflammatory type of odontogenic cyst. This inflammatory type of odontogenic cyst. That is, the most common is the periapical cyst. The name itself is very important. This is the most common type of odontogenic cyst. Among all the odontogenic cysts, developmental or inflammatory, periapical cyst is the most common type of cyst occurring in the oral cavity. It is occurring as a result of chronic inflammatory process. When it is usually associated with a traumatic tooth or a deep carious tooth, untreated carious tooth, or an improperly restored tooth. Usually, when you suspect a periapical cyst, the involved tooth, the culprit will be either a carious tooth, which is not restored properly, or a non-vital tooth. Radiographically, the periapical cyst present as a radiolucent lesion, occasionally exhibiting a thin radiopaque line around the periphery. See, that's a typical. See that particular tooth, the central incisor, lateral incisor, CT treated, root canal treated, improper filling. May see the radiolucency around the in the periapical region, well defined radiolucency. Now, in periapical cyst, the pathogenesis is very important. How the periapical lesion become a periapical cyst. We know we have learned the pulpitis, the secular pulpitis is could either lead to periapical abscess, periapical granuloma, or periapical cyst. The periapical granuloma, how it epithelializes is very important. This is the flow chart which depicts the periapical cyst formation. And the involved tooth could be a carious tooth or a traumatic or non-vital tooth. And from there, the bacterial endotoxins are released from the necrotic pulp into the periapical region, leading to periapical inflammation. From there, it could either progress as a breakdown theory or abscess theory or epithelialization theory. Here, that is the pathogenesis of periapical cyst. It could stimulate the epithelial cell rest of molasses. It could lead to proliferation of the epithelial mass. The central mass gets deprived of the nutrition. The cavity and liquefaction necrosis occur of the central cells and leading to radicular cyst formation. And another method of flow ways through the proteolytic enzymes activity in the connective tissue. The space will be formed in the connective tissue breakdown. Epithelialized cells will line those cavity, the abscess, that is the abscess cavity theory, leading to a periapical cyst. So it could progress as a periapical abscess, fistulization of the oral cavity, and then get closed by the epithelialization of the fistulous tract. Then the epithelial cells will colonize the abscess, and again periapical cyst is formed. This flowchart is very easy to learn. It's very important. Once the pathogens of periapical cyst question was there. Then histopathologic features are very important. Again, this can be asked as a short note question for a periapical cyst. Again, a cyst has got a connective tissue capsule and epithelial lining. Connective tissue capsule is usually collagenous, densely infiltrated with the chronic inflammatory cells, especially the lymphocytes and plasma cells. The epithelium lining consists of usually a stratified squamous epithelium. It may be either a few cells thick or it may undergo proliferation due to inflammation, leading to arcading pattern characteristic of periapical cyst. And in the connective tissue capsule, chronic inflammatory cell infiltration is dense. There may be multinucleated giant cells. The presence of cholesterol crystals, cholesterol clefting may be noticed in the histopathology of the connective tissue capsule of the periapical cyst. Again, being an inflammatory cyst, Rushton bodies may be noticed. Rushton bodies can be seen in any cyst which are infected. And these are halide bodies which are linear, arc-shaped, they're refractive, non-birefringent, seen in the epithelium. They're amorphous in structure, eosinophilic, and brittle in nature. The lumen of the periapical cyst contains a watery, straw color or bloody tinged fluid to semi-solid materials. The lumen may also contain cholesterol crystals. So that's the histopathology of periapical cyst. It has a connective tissue capsule. It has got epithelial lining. It has got a lumen. And this picture is very important. You will be familiar with the typical histopathologic diagram of periapical cyst. See, it has got a connective tissue capsule which is infiltrated densely with chronic inflammatory cells. The epithelial lining is stratified squamous epithelium, producing the typical arcadic pattern. Lower diagram shows the presence of a lot of cholesterol clefting. So the picture is very important. Giant cells with the proliferating blood vessels with the inflammatory cell infiltration is there, presence of cholesterol crystals are there. Coming to the treatment of periapical cyst, it is treated either with a root canal therapy, a periapical surgery, or extraction with periapical curettage. That is periapical cyst. When a cyst occurs later stage after extraction of a particular tooth, when a cyst occurs in that area, then that is we call it as residual cyst. Okay, that is an occurrence of a cyst from the residues of my previous pathology. That is residual cyst. So with that, I am finishing and winding up my topic. These are the important lesions from odontogenic cyst. The lesions we brushed up are Dentigerous cyst, odontogenic keratocyst. Then we have seen the lateral periodontal cyst, gingival cyst of newborn and adult, eruption cyst. Then we have just mentioned the Bond's nodules and Epstein pearls. Then the inflammatory type of cyst include the periapical cyst, very important, and that is the most common type of cyst of oral cavity. With that, I am winding up my topic. I thank the organizing team for including me also in the panel discussion or the review program.
Thank you so much, sir. That was an informative and elaborative session on odontogenic cyst, especially developmental and inflammatory cyst. Now we are moving on to the next speaker. Introducing the speaker, Dr. Anthony George is Professor and HOD at MES Dental College and Hospital, Perindalmanna. He completed his undergraduation from A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, and post-graduation from Ragas Dental College, Chennai. He has more than 27 years of clinical experience, especially in aesthetic dentistry and cosmetic surgeries. He is one of the few with a private practice in oral pathology and is associated with Metropolis Healthcare Laboratories Private Limited since 2007. He has more than 25 peer-reviewed indexed international publications and is associated with editorial boards and peer review boards of various journals. He is a PhD guide at MES Center of Research under Kerala University of Health Sciences and is associated with Institutional Ethics Committee and Research Advisory Committees. Proudly, we welcome you, sir.
Hi. It is during our darkest moments that we must focus to see this light. Aristotle. I am Dr. Anthony George, and today we are here to discuss about odontogenic tumors, specifically the Ameloblastoma. If we look at the term Ameloblastoma, we can easily split it up into two terms. Ameloblast and oma. Ameloblast we are very familiar with. It is the inner enamel epithelium during the Bell stage that differentiated into the tall columnar cells, which we started to name it as ameloblast, which was the cell that was responsible for the laying down of enamel through the process of amelogenesis. And oma usually stands for a benign lesion. So the name itself now helps us to identify that this is a benign tumor arising from subabnormality during this development of tooth. In other words, Odontogenesis. The question arises, is this an important question or a topic to study? And the answer to that is on the screen. Even though it is crowded, you will see that in 2014, 2015, 16, 17, 18, 20, almost every year, the university question paper had this topic as an essay question. So using this as an agenda, the previous oral pathology question papers, I have decided to talk depending on or based on first the classification of odontogenic tumors. Remember that always an essay question, 99.9% will start with the question classify. It could be an organ tumor or a cyst or salivary gland, whatever it is, it should or usually starts with a classification. So it is very important to understand and learn a classification about that specific tumor or lesion. And try to learn the most recent classification, because if you look into your textbook, there will be a number of classifications, but you should be able to clarify and write properly at least one classification, preferably the latest one. The second question or the topic that we can talk about is the definition of Ameloblastoma. The third one is the clinical features of Ameloblastoma. The fourth one, the radiographic features of Ameloblastoma. And the fifth one will be the histopathology of Ameloblastoma. And being the oral pathology paper, the histopathology of Ameloblastoma will, of course, will carry the maximum marks. And hence, when we are preparing for an answer, for an essay question or a short note, make sure you concentrate more for the histopathology of Ameloblastoma rather than the clinical features and radiographic features and treatment, etc., which is important if you are appearing for a oral medicine paper or a surgery paper. But right now, we are trying to think about an oral pathology paper. So let's take up the first one, the classification of odontogenic tumors. Ambrose Bierce long time back said the small part of ignorance that we can arrange and classify, we give the name of knowledge. So I am trying to follow the WHO 2017 classification of odontogenic tumor that was published in this so-called Blue Book of WHO. So in 2017, WHO starts the classification from the malignant lesions. So we have the odontogenic carcinomas, we have the odontogenic carcinosarcomas, and then the sarcoma. The carcinomas, they have gone ahead and grouped it under ameloblastic carcinoma, primary intraosseous carcinoma, sclerosing odontogenic carcinoma, clear cell and ghost cell odontogenic carcinomas. The fourth one is of interest today, which is the benign epithelial odontogenic tumor, and that is our Ameloblastoma, squamous odontogenic tumor, calcifying epithelial odontogenic tumor, or our Pindborg tumor, Adenomatoid odontogenic tumor. Ameloblast, they again went ahead and clinically classified it or divided it into three types: Unicystic type, extraosseous or peripheral type, and the third one, metastasizing ameloblastoma. as I'm going to discuss later on about metastasizing ameloblastoma, right now I won't be talking about a little confusion that exists from the previous classification. Moving on with the fifth classification, under WHO 2017, we have the benign mixed epithelial and mesenchymal odontogenic tumor. Mixed standing for that the component from which this tumor can arise from is both epithelial and mesenchymal of our bell stage. Those lesions, according to WHO 2017, is ameloblastic fibroma. Primordial odontogenic tumor, which is the recent tumor that is added onto this classification. Odontoma, which is the most common odontogenic tumor, and the dentogenic ghost cell tumor. Odontoma, hopefully you know, is of two variants, the compound type and the complex type. Moving to the last part of the classification, which is the benign mesenchymal odontogenic tumors, we have the odontogenic fibroma, odontogenic myxoma, cementoblastoma, and the recently added cemento-ossifying fibroma. Chances are that in your textbook, you may not find these two lesions under odontogenic tumor chapter, but you may find it under the bone lesions or more specifically the fibro-osseous lesions. So this edition is in the 2017 cemento-ossifying fibroma, being considered as an odontogenic tumor now. So that completes our classification. Carcinoma, carcinosarcoma, sarcoma. Benign epithelial odontogenic tumor, benign mixed epithelial and mesenchymal odontogenic tumor, and the current one, benign mesenchymal odontogenic tumor. Moving on to the next part, which will be how to mug up the definition of ameloblastoma. This definition or define ameloblastoma is frequently asked as a viva question also. Abdul Kalam, our favorite president, said, "We should not give up and we should not allow the problem to defeat us." Before I move on to the definition per se, I would like to talk about the synonyms of ameloblastoma, meaning this lesion or ameloblastoma, which is the benign epithelial odontogenic tumor, is also known by different terms or synonyms. Conventional ameloblastoma, to differentiate, that terminology is used to differentiate it from the other three clinical variants that we discussed under the classification, WHO 2017 classification. Remember them? Unicystic ameloblastoma, peripheral or extraosseous ameloblastoma, and the metastasizing ameloblastoma. The second synonym is the solid multicystic ameloblastoma, and a very old term that is now discarded is adamantinoma. So with that, I'll move on to the definition of ameloblastoma, which was given by Robinson way back before we were born in 1937. So we can appreciate how old that definition is and how old this discovery of ameloblastoma was. He defined it as an odontogenic epithelial tumor that are usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. You need to mug it up, and we cannot use our own terms because this is defined. This is a definition that has been defined by Robinson. So we need to use these words after understanding them, of course. Unicentric, It is a non-functional tumor. It's not producing any tooth. It's not any functional organ. It's a non-functional growth, which is intermittent. And that means it's not that it is suddenly growing in size. It slowly grows. Maybe it grows and stops and then grows into intermittent in growth. Anatomically benign. This is not a malignant lesion. It is definitely a benign lesion. Clinically persistent, meaning that persistent. Or a lesion which will remain or grow in size or persist when no treatment is done. Usually these lesions are asymptomatic, and so the patient may not come to you for treatment, in which case it can grow slowly to a large size. So we usually try to recollect these terms using this UNIAC as an acronym. Unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. If anybody is interested in the newer classification or the newer definition that came up in 2017 by the WHO, they call it as a benign intraosseous, progressively growing epithelial odontogenic tumor characterized by bone expansion and a tendency for local recurrence if not adequately removed. So that is more understandable, but we always try to learn and mug up the Robinson 1937 classification, because over the generation, my teachers and their teachers have been talking about this definition. So usually the faculty or the examiner expects the Robinson 1937 classification or the definition when they're talking about defined ameloblastoma. So moving on to the third part of the agenda of my lecture on ameloblastoma, the benign epithelial odontogenic tumor, which is the clinical features. Louis Hall said, ability is what you're capable of doing. Motivation determines what to do. And attitude determines how well you're going to do it. Before starting with the clinical features in detail, I'd like to talk about pathogenesis. Pathogenesis is trying to detect how did this odontogenic tumor arise. So it could have come from the cell rest of Surrey or the cell rest of Malaise. Hopefully these two cell rests are familiar with you. Remnants of dental lamella, Surrey. Remnants of Hartwick's epithelial root sheet or HERS, Malaise. Two names of two different scientists who discovered these remnants first. One is a remnant of dental lamella, the other the remnants of HERS. It could also arise from our reduced enamel epithelium of enamel organ. Please remember that after the ameloblast has laid down the enamel, what happens to it? It reduces in size, becomes a cuboidal cells, and we call it as reduced enamel epithelium. We are talking about that epithelium. Third could be the epithelial lining of odontogenic cysts. Cysts, hopefully you understand cysts, and you know that there are two definitions of cysts, and you appreciate there are true cysts and pseudocysts. And if you understand true cysts, you should know that they are always lined by an epithelium. And I'm sure you heard about Vickers and Garland's criteria. You should. I'm right now not going to discuss about this criteria, but whenever I'm going to start on unicystic ameloblastoma, I may talk about a little bit on these criteria. And the last one is the oral mucosa basal cells. Remember our basal cell, oral mucosa, stratum basal, also known as germinative layer or germinatum, or because they contain the stem cells or the progenitor cells. So these basal cells have the ability to differentiate into any cell, which unfortunately can produce a benign epithelial odontogenic tumor. Researchers have gone ahead and tried to study the ameloblast in detail, and they have come up with a genetic profile for this tumor. And let's look into that. Mutation in oncogene BRAF is associated with mandibular ameloblastomas. Mutation in SMO, or the smoothed gene, and the RAS gene is associated with maxillary ameloblastoma. And both maxillary and mandibular ameloblastoma has shown an overexpression of epithelial growth factor receptor and RANK-L. So this is the genetic profile of ameloblastoma. BRAF for mandibular ameloblastoma, SMO and RAS for maxillary ameloblastoma, and both are showing an overexpression of EGRF and RANK-L. Moving on. The epidemiology or the incidence, how common is it? This is the second most common odontogenic tumor following odontoma. So why the question? Which is the most common odontogenic tumor? Answer, odontoma. Remember, this was classified or is classified under benign mixed epithelial and mesenchymal odontogenic tumor, whereas ameloblastoma is classified under benign epithelial odontogenic tumor. So ameloblastoma is the most common benign epithelial odontogenic tumor. Yes. And it is the second most common odontogenic tumor. So it's always important to listen to the question carefully when the viva is being conducted. If the question is which is the most common or which is the most common odontogenic tumor, answer is odontoma. And the question is which is the most common benign epithelial odontogenic tumor, your answer should be ameloblastoma. Hope I made a clarification on the little bit, the difference in the question and of course the answer. Epidemiology always will have different subheadings. So we talk about age. This lesion can be seen in individuals or children as young as 8 years, even though it is rare below the age of 10 years. And it can be seen in as old as 92 years grandpa or grandma. Yes, so from younger age group to a very old age group, a huge range. Mean age is around middle age 34 years. Gender, there is no specific gender predilection. So both the males and females are kind of equally affected with ameloblastoma. Race, it is more commonly, statistically more commonly seen in the blacks compared to us, the Asians and the Caucasians. Statistically, more common in blacks. Where or which is the site where you can find the ameloblastoma most commonly? The mandible. Majority is in the mandible, not in the maxilla. Where in the mandibular jaw? The angle ramus. This is the angle. Yes, and this area is our ramus. So large majority is found in our angled ramus region of our mandible. Small percentage is found in the maxilla, which could be in the anterior region or in the molar tuberosity region. Moving on to the signs and symptoms, remember we are talking about the clinical features of Ameloblastoma, the benign epithelial odontogenic tumor. Signs and symptoms. It is painless, in other words, asymptomatic, slow, progressive. Remember, we said, we already talked about it, intermittent in growth. Bony expansion, because 19% or 99% is seen inside the bone, inside the jaw. Right? So clinically, the patient may come to you with a asymptomatic swelling of one side of the jaw, usually 80% involving the angled ramus of mandible. I did say it is painless, but sometimes it can become painful if it gets infected, secondly infected, or if the tumor is growing to a large size, a huge tumor, and goes and impinges or gives pressure on our nerve. Which nerve? Inferior alveolar nerve. That is a nerve which is inside our jaw. So it has to be inferior alveolar nerve. If it is a mandibular lesion, usually it is the mandibular lesion that we're going to talk about when we talk about Ameloblastoma. So pressure on this nerve can cause pain, or it can cause the opposite, which is paresthesia. Paresthesia, numbness or loss of sensation. Where? What happens to the inferior alveolar nerve? It comes out of the mental foramen and supplies the skin and the surface of these areas. So if something is happening to the inferior alveolar nerve, what are you going to have? You're going to have a numbness here, and of course the numbness of the gingival area. This growth, bony expansion, slow, painless bony expansion can cause mobility of the teeth, which is inward, malocclusion, restricted mouth opening, in other words, trismus, facial deformity or asymmetry of the face. On palpation, hopefully you can understand what palpation is. Yes, so far we were talking about signs and symptoms. What is the patient going to come to you or complain to you? We inspected that lesion and now we are palpating it with our gloved hands. And when we palpate, we can feel two things. One is the tennis ball-like springy consistency. I'm sure all of us are very familiar with this tennis ball. And if you bounce it, you can see this springiness. So when we palpate this painless swelling in the angle of mandible with our gloved fingers, we are going to feel this springy-like consistency, which we are going to kind of define as tennis ball-like springy consistency. The second thing that you can appreciate or you can hear is the egg shell crackling sound. Hopefully all of you have broken an egg and you have heard that crackling sound, or better known as crepitation. So on palpation, remember these two terms, tennis ball like springy consistency and eggshell crackling or crepitus sound. I have a question. If you are appearing for any MCQs in the future, you have the answer for that. So with that, I move on to the fourth agenda of our discussion, which is radiographic features of Ameloblastoma. When a man's knowledge is not in order, the more of it he has, the greater will be his confusion. So that is very important when we're trying to study something. If we don't have a systematic plan to study, we don't plan it out properly, when we sit for the exam and try to recollect what we studied, it will be a one big jumbled mass. And our answers are not to be good enough for the examiner or the faculty to read and give you good marks. So it's always important to study systematically. The answers, when you're writing it, should have headings and subheadings. The presentation of the answer is very important to get good marks. Coming back to our Ameloblastoma, the benign epithelial odontogenic tumor, radiographic features. Usually, if you take a radiograph, hopefully you know much about radiographs, so we will talk about two films at least, the OPG and the IAOPR. Yes, two radiographs. Hopefully you understood the two terms. Because of paucity of time, I'm not going into details of that radiographic films. What you're going to see is multilocular radiolucency. Two radiographic terms, hopefully which you are familiar with. Radiolucency is opposite of radio opacity. So lucency is kind of black. Opacity, you know from physics days. Opaque is a white. So opposite to that is lucent, radiolucency. Locular, when you have loculation, English word, locular, loculation. When there are multiple of them, of course it is multilocular. Opposite to this will be unilocular. So this multilocular radiolucency has been defined as or grouped under soap bubble appearance and a honeycomb appearance. Soap bubble? I'm sure all of us have blown the soap bubble whenever we had some festival. Yes, before the corona, of course, we went and brought all those things and we used to blow and create soap bubbles. So you know what soap bubble is. Honeycomb, honey, our bees. Yes, their home is the beehive, and that beehive is also known as honeycomb. So you know the appearance of a beehive. So they're just comparing it with that appearance. So the soap bubble appearance term is used when the loculations are large. If you can appreciate this OPG image, you're looking at the angled ramus of mandible of an edentulous patient. No teeth on the upper jaw, no teeth on the lower jaw, edentulous patient, angled ramus mandible, and you can see one loculation, two loculation, three loculation, and lots of loculation which are smaller. So if you see such big loculations which are multiple, we are going to term it as soap bubble appearance. If the loculations are small, then we are going to call it as honeycomb appearance. So the smaller loculations, we are going to call it as honeycomb. There's a third pattern which is known as spider web pattern. Very rarely you can see the trabeculae radiating from the center to the periphery. So a kind of center area like the body of the spider and like the legs of the spider, you can have radiations. Trabeculae running in that pattern. So in that case, we call it spider web pattern. But at least remember soap bubble and honeycomb pattern, which is the multilocular appearance, radiographic appearance of Ameloblastoma, the benign epithelial odontogenic tumor. So the majority, 86%, is multilocular, but the smaller percent will be unilocular, radiolucency. And yes, a large number of these radiolucencies are associated with unerupted or impacted displaced teeth. If I be permitted to rub off all what or erase off all what I marked, I don't know, did you appreciate this in the radiograph? Did anyone appreciate this in the radiograph? What is that? That is our third molar, mandibular third molar, forehead, impacted and displaced. Yes, it has been displaced. Should have been somewhere here. Follicle would have been somewhere here. And the tooth never erupted. And this could be the tooth or the follicle from which this Ameloblastoma, huge benign epithelial tumor, arose from. So that's what I'm trying to say here. In unerupted, displaced teeth is usually associated with this multilocular radiolucency in the angle ramus mandible of a patient with Ameloblastoma. This unilocular radiolucency can also be mistaken for Dentigerous cyst. If you had appreciated that impacted tooth and if you had seen a radiolucency surrounding the crown of this impacted tooth, the first diagnosis, provisional diagnosis, of course, should be Dentigerous cyst and sometimes the Odontogenic keratocyst, OKC. So the Dentigerous cyst and the OKC, two cysts, Odontogenic cysts, are the usual picture where you find an impacted tooth with a radiolucency. So radiographically, you may mistake a Dentigerous cyst and Odontogenic keratocyst, in which case normally after histopathology you may report it as Ameloblastoma. So you may have a radiographic report saying Dentigerous cyst or an OKC because that is the most commonly seen radiographic picture. But once you take a biopsy and take a histopathology or do a histopathology, you may get a report saying Ameloblastoma, which is a benign epithelial tumor, which is a tumor and not a cyst. Margins of this multilocular radiolucency or unilocular radiolucency is usually well corticated. Again, a radiographic term, well corticated, smooth, or sometimes it is scalloped. Hopefully, you can appreciate all these radiographic terms. Buccolingual cortical plate expansion is there. Buccolingual expansion, different from mesodistal expansion, which is a characteristic feature of mesodistal expansion is a characteristic feature of. Hopefully you know that. I'm not giving you the answer. If you don't know it, go and find it out. But this Ameloblastoma is buccolingual expansion, cortical plate. Hopefully you understand cortical plate. So if you can appreciate this CT here, you are seeing a unilocular buccal cortical plate expansion at the angle of ramus of mandible, of course. Resorption or displacement of the involved root. If you can appreciate this IAOPR, can you appreciate the resorption of the apex of this canine, this lateral incisor, this central incisor of mandible? The apex has been resorbed. And of course, the first premolar, mandibular premolar is here, whereas the canine root is here. So the canine root has been displaced by this benign epithelial odontogenic tumor, in other words, Ameloblastoma. Large lesions are usually associated with pathological fractures. Again, I don't know if did you appreciate that feature in this OPJ? Because this is a huge tumor affecting almost half of the mandible. This lower border has become so thin that it could have caused a fracture, which will be known as pathological fracture. So that is the radiographic features of ameloblastoma. I quickly move on to the main part of our discussion, which is the histopathology of ameloblastoma. Yes, histopathology of ameloblastoma, which is the important question from the point of view of an oral pathologist or oral pathology question paper. There are 6 major variants, histopathological variants: follicular, plexiform, acanthomatous, granular cell, basal cell, and desmoplastic. I'll be explaining each as I go forward. Remember, there are more rarer variants which we will not be discussing at this period. We will be discussing the more commonly seen 6 histopathological variants of ameloblastoma, the benign epithelial odontogenic tumor. Taking up the first one, the follicular ameloblastoma. This is the most common histopathological variant of ameloblastoma. Conventional ameloblastoma or solid multicystic ameloblastoma. Histopathologically, most common variant is follicular ameloblastoma. Hopefully, you can see the histopathological image, photomicrograph on your screen. So what you're seeing, variable-sized islands of odontogenic epithelium. Odontogenic epithelial islands of variable size. Some are small, some are big. And if you look closely at those islands, can you appreciate the single peripheral row of tall columnar ameloblast-like cells at the periphery of the island? Of one odontogenic island, if you take up the periphery, this is the basement membrane, what I'm drawing. On top of the basement membrane, what you're seeing are the tall columnar cells. I'm trying to draw with my mouse, so it will not be a good diagram, of course. So you're seeing a tall columnar cell, which is having a hypochromatic, palisading, reversal of polarity of the nucleus. The blue color or the hematoxin color stain is our nucleus. So hopefully you can appreciate all the nucleus are hyperchromatic, darker in color. Chromasia, color, hyper, darker, hyperchromatic in color. And they are all arranged in nice looking line. So it is palisading. When you look little closer, you may find that the basement membrane is here and the nucleus is shifted away from the basement membrane. So that is what? Reversal of polarity. Remember, ameloblast as such was a secretory cell. If it is a secretory cell, the nucleus will be shifted away the basement membrane so that the cell organs can come towards the one area of the cytoplasm so that they can secrete whatever it is required of that secretory cell. So I told you 3 terminologies here: hyperchromatic nucleus, palisaded nucleus, and reversal of polarity of the nucleus of which cell? The single row of peripheral tall columnar cells. So what is the cells in the center of this odontogenic island? They are the stellate reticulum-like cells. Stellate, star, reticulum, meshwork. So we know those terminologies. So we are having a stellate reticulum-like cells in the center of this island. The follicles frequently show cystic degeneration and hence the term multicystic ameloblastoma. Remember, solid multicystic ameloblastoma. Can you appreciate the cystic degeneration within these stellate reticulum-like cells? That was a small cyst. This is a large cyst. This is even a bigger cyst. There's another cyst here. There's another cyst here. So it is multicystic. The surrounding stroma, if you look at, you find it is mature, dense, and often hyalinized. Can you appreciate the stroma here? So that is how we're going to write about follicular ameloblastoma, the most common variant of ameloblastoma. Moving on to the plexiform ameloblastoma, the second most common variant of histopathological variant of ameloblastoma. Quickly look into it. Instead of islands, what we are seeing in this histopathological micrograph, photomicrograph, is strands, networks or cords of odontogenic epithelium. In follicular ameloblastoma, we had follicles, nests or islands. Here we are having our plexiform ameloblastoma, which has networks, strands and cords of course, the odontogenic epithelium. Looking closely, the same things. Peripheral row of single tall columnar ameloblast-like cells showing hypochromatic palisaded reversal of polarity of the nucleus. Hopefully you can appreciate the basement membrane, okay, the basement membrane and the tall columnar cells, single row sitting on top of that. The central area, if you look at, these are the stellate reticulum-like cells. Hopefully you can appreciate the star-shaped cells. If you look at the surrounding stroma, it is fibrous, it is vascular and more loosely arranged compared to your follicular ameloblastoma. Now there's a frequently confusion that happens when we do our practicals or when you're going to do that. You people, the students think this is a follicle. Is it? Is this the follicle? The things that I'm drawing is a follicle? Sorry, that is not the follicle. This is the strands of odontogenic epithelium. So what are these areas? These entrapped areas are our connective tissue stroma. What you're seeing is the collagen fibers. In this particular image, what you're seeing is the cystic degeneration of that stromal core. So hopefully you'll be able to appreciate the difference between plexiform ameloblastoma and follicular ameloblastoma histopathologically under the microscope. Okay, so please don't mix it up. These are not follicular areas. These are connective tissue cores. In this specific image, what you're seeing is the cystic degeneration of the connective tissue. In follicular ameloblastoma, I told you it is the cystic degeneration of stellate reticulum cells. Hopefully you appreciate the difference. The third most common variant, acanthomatous ameloblastoma. Hopefully you can appreciate the image on the screen. You are again seeing what? Follicles and islands of odontogenic epithelium of varying size. Like in follicular ameloblastoma. We are seeing peripheral, tall columnar, ameloblast-like cells with hypochromatic nucleus, palisation, and reversal of polarity. We are also seeing the central stellate reticulum-like cells. But we are also seeing, I'm not very sure, did you appreciate these cells here? Did you appreciate these cells here in this follicle? Did you appreciate this large follicle, which these cells are these stellate reticulum cells? This is the stellate reticulum cells. Does it look like stellate reticulum cells? Definitely not. So what is that? That are squamous cells. So how did that squamous cells happen? Through a process of metaplasia. So metaplastic transformation, again, hopefully you understand the term metaplasia. If not, please go back and read about it. So the stellate reticulum cells, the central cells sitting in the center of our odontogenic island, underwent a metaplasia to a squamous cell. So if you see an odontogenic island of varying size with central areas of stellate reticulum plus squamous metaplasia, you are going to call it as acanthomatous ameloblastoma. And sometimes, if you can appreciate this island in this image, the whole of stellate reticulum is undergone metaplasia and we are having squamous cells. And we are even having a keratin pearl. Keratin pearl. Where have you heard that? If you have studied squamous cell carcinoma, you would have talked about or heard about keratin pearl. So actually this picture, the second picture here, looks like a squamous cell carcinoma and you should not mistake it for an intraosseous squamous cell carcinoma. you should look at the other islands. You look at the other islands, you are going to see features like this, and then you're going to call it as acanthomatous ameloblastoma. Quickly moving on to the fourth variant, histopathological variant of ameloblastoma, the benign epithelial ornate tumor is granular cell. So as you can look or see at the picture, you're seeing a granular cell. Just to remember, we are looking at high power. So actually we are looking into one odontogenic island. So remember, you have multiple odontogenic follicles of varying size. And now we are looking into the high power so that I can help you to understand that granular cell or focus more on that granular cells. So what we are having, we are looking at a magnified view of one follicle of odontogenic epithelium, and we still can appreciate the peripheral cells, but we are not appreciating tall columnar ameloblast-like cells. Instead, we are appreciating the cuboidal cells with hypochromatic nucleus, darker stained nucleus, but you may not appreciate the palisading or reversal of polarity because this is not a tall columnar cell, this is a cuboidal cell. Okay, that is the periphery of this follicular island, and if you look at the center, what you should be seeing should be the stellate reticulum cells. But instead of stellate reticulum cells, we are seeing such granular, large, round, ovoid, round cells with a peripheral nucleus. Yes, so that is why, because of this histopathological feature, we are calling it as granular cell ameloblastoma. So basically, we are seeing follicles of ameloblastomatous odontogenic epithelium, but the picture is a little different. Instead of palisaded, hypochromatic, reversal polarity, ameloblastomatous cells, we are seeing peripheral cuboidal cells, periphery of the island, odontogenic island. In the center, we are not seeing stellate reticulum cells, but we are seeing the major area filled with granular cells. So researchers went and studied why these cells are granular in appearance, and they found out that it contains lysosomes ultrastructurally and histochemically. So these granules are lysosomes. These are acidophilic or eosinophilic granules, cytoplasmic granules seen in this ovoid or round granular cell. Some clinicians and researchers consider it is more aggressive than the other variants. We did talk about 6 different variants. Yes, of that, some people consider granular cell and also the basal cell variant of ameloblastoma to be comparatively or little more aggressive comparatively to the other follicular plexigonga edematous. Compare it with the other, statistically they find that this is a little bit aggressive, more aggressive, locally aggressive. Moving on to the 5th one, basal cell ameloblastoma. Again, I have put up a high power to appreciate the basal cells. So this is one follicle of our odontogenic epithelium. So again, we are looking at the follicles of odontogenic epithelium of varying sizes. Now I'm focusing on one follicle, and what do you see? You see a peripheral area of cuboidal or our columnar ameloblast-like cells with hypochromatic nucleus. And hopefully you can appreciate the palisading appearance. Hopefully you can appreciate that the nucleus is shifted away from our basement membrane. Yeah? But what about the central stellate reticulum cell-like cells? Are we seeing that? No. We are seeing again the same type of cell population. The basaloid transformation of stellate reticulum cells have occurred. Basaloid, resembling basal cell, transformation of our stellate reticulum-like cells. in the center area. And because of this picture, we are going to call this as basal cell ameloblastoma. So these basal cells are primitive cells. Can you appreciate the vesicularity of the nucleus? Can you appreciate the nucleoli? Can you appreciate the chromatin strands? So they are more primitive cells. They resemble the basal cell carcinoma of skin histopathologically. Okay. Suddenly, if you see it, the general pathologist may think of basal cell carcinoma as skin. So it is very important when you're giving a biopsy specimen to identify the site, the clinical features and radiographic features to the histopathologist to make sure the histopathology report is more accurate. Researchers believe that this basal cell ameloblastoma is the least common type of histopathological variant of ameloblastoma. So the most common histopathological variant of ameloblastoma, follicular ameloblastoma. The least common variant, histopathological variant of ameloblastoma, basal cell ameloblastoma. As I said before, some researchers or some clinicians consider this basal cell and granular cell ameloblastoma a little more aggressive compared to the other one. Moving on to the last one. On this histopathology of ameloblastoma, the desmoplastic ameloblastoma. Okay, I'm talking about desmoplastic ameloblastoma here because I'm following the 2017 WHO classification. Hopefully that little point is clear, because if you look at the older classification, you would have found this desmoplastic ameloblastoma as a clinical variant after Unicystic, after peripheral ameloblastoma. You would have found desmoplastic ameloblastoma, not metastasizing ameloblastoma. Whereas in 2017 WHO classification, things have changed a little. In some areas it's changed a lot. So I'm talking about histopathological variant of the conventional ameloblastoma or our solid multicystic ameloblastoma, desmoplastic ameloblastoma. What are you seeing? You are still seeing the odontogenic islands. Hopefully you did appreciate these funny shaped, not that round and follicles and neatness that we found previously. You're kind of finding it compressed, kind of shapeless or shaped odontogenic epithelial islands. They are all compressed. So we are seeing proliferating, irregular, bizarre shaped islands or thin cords of odontogenic epithelium. Can you appreciate the peripheral cells? Yes, they are cuboidal cells. They are dark, hypochromatic. But the characteristic features of ameloblastoma, which was hypochromatic, palisading, reversal of polarity, may not be appreciable. I'm sure you're not able to appreciate it here in this island. Okay? Because it's compressed. It is being compressed. Why? Why it is compressed? Because there is extensive desmoplasia. Desmoplasia. Again, another histopathology term, which if you are not familiar, please go up and read up on desmoplasia. Dense collagenation or fibrosis of the connective tissue stroma, which hopefully you can appreciate. The number of connective tissue stroma, the area of connective tissue stroma with hyalinization is more, isn't it, in this histopathology? The odontogenic epitheliums are comparatively very little areas. And whatever areas you're seeing the compressed areas of these odontogenic islands. You may also find osseous metaplasias. Can you appreciate this bit of bone? So you may have desmoplastic changes in the collagen fibers, and also you can find metaplastic changes into bone, osseous metaplasia. So this is the reason, hopefully you got the reason why the previous classifications older classification to WHO 2017 kind of grouped it separately. Because as you can see, the histopathology picture is kind of drastically different from what we saw. Okay, we are seeing more of this connective tissue stroma. Desmoplastic connective tissue stroma. That's why it's called desmoplastic ameloblastoma. That's how that name came, desmoplastic ameloblastoma. Instead of seeing those large follicles of odontogenic epithelium, we see compressed odontogenic epithelial islands. We are not able to appreciate the peripheral cells. We are not able to appreciate the stellate reticulum cells at all because they are kind of thoroughly compressed. Okay, and this desmoplastic ameloblastoma is little different, not only histopathologically, it is little different biologically and clinically and radiographically. So I just quickly go through that and then come to the end of our talk today. Okay, so I said desmoplastic ameloblastoma is a histopathological variant of conventional ameloblastoma or solid multicystic ameloblastoma, but as you can see, the histopathological variant is different. And also, they are a little more different. What are the other different things? The clinical features, if you look at, you will find that it is more commonly seen in the maxilla. Like in this picture, you're seeing that this desmoplastic ameloblastoma is not seen in this angle ramus of mandible, but 80% of scene is seen in the maxilla where anterior region. The other conventional multicystic ameloblastoma, we said mandible is the most common jaw affected. Then we said it is the posterior area. Which area? Angle ramus and all that we said. Now this desmoplastic is a completely different story. It's more common in the maxilla, not in the posterior. Anterior maxilla, anterior premolar region is where we usually find 80% of these desmoplastic ameloblastoma. Can you appreciate the radiographic image here? Yes. So you can hopefully able to appreciate the mixed radiopaque radiolucency with ill-defined borders. Remember our conventional ameloblastoma, solid multicystic ameloblastoma? We talked about multilocular radiolucency. Here I am saying it is mixed radiolucent radiopaque lesion. Usually that is seen or is an image of fibrous lesion. More commonly, if you see this mixed radiolucency, the radiographic image that goes through our head is, okay, could this be a fibrous lesion? But if you do a biopsy and do a histopathology, they might get reported as desmoplastic ameloblastoma. So another thing is, if you can see, the margins are not very well defined and corticated, they are ill-defined margins. And of course, they are expansile lesions. The whole maxillary alveolar bone, cortical and lingual plate has been expanded. So desmoplastic ameloblastoma is little different. Yes, histopathologically different. Desmoplasia is seen compressing the odontogenic epithelial islands, hence the term desmoplastic ameloblastoma. Clinically, little different. Site is completely different. Anterior maxilla. Radiographically, little different. Not that usual multilocular radiolucency of our ameloblastoma, but a mixed radiopaque radiolucency that also in the anterior maxilla. So, we come to the end of this long discussion about ameloblastoma. Our agenda screen, I didn't talk about treatment of ameloblastoma, but I did cover classification of odontogenic tumors. Yes, carcinoma, carcinosarcoma, sarcoma, benign epithelial odontogenic tumor, where ameloblastoma is, benign mixed epithelial mesenchymal odontogenic tumor, where our odontoma is, and benign mesenchymal odontogenic tumor. Then I gave you the definition of ameloblastoma. Yes. Then we finish the clinical features. Then we finished the histopathological variants, 6 histopathological variants of Ameloblastoma in detail. And to complete our answer, I'm just going to spend 2 minutes on the treatment of Ameloblastoma. I'm not going to talk about it in detail because for an oral pathology paper, treatment is to be done by the surgeons. So that is a oral and maxillofacial surgery question paper and not an oral pathology paper. So just to complete this episode on Ameloblastoma, I'm just going to mention briefly or give you an overview of the treatment of Ameloblastoma. The treatment of Ameloblastoma will depend on the size, where it is located, anatomical location. Histopathological variant can be affected or can influence, but the amount of structure that is involved, of course, is a consideration for treatment planning. If it is a maxillary lesion, it is involving the maxilla. If it is involving the nasal cavity, is it involving the lower rim of the orbit? Okay, so that is the structural involvement. Anatomic location, same place. How much bone should I remove? So always remember that Ameloblastoma is locally invasive or aggressive, even though it is a benign tumor. And it is always associated, or 90% is, or 80% is associated with high recurrence rate. Recurrence, it will come again after treatment, after surgical treatment. The patient may come back to you and tell you, sir, you did that surgery before, but now I have the same problem again. So you have to be careful. You have to be a good surgeon. So remember that Ameloblastoma is a locally aggressive or invasive, but a benign odontogenic tumor with high recurrence rate. And the treatments could be, if it's a very small lesion, I told you it depends on the size, location, histopathological variant and structural involvement. If it is a small lesion and not involving much of the bone, we talk about enucleation with curettage. The maxillofacial surgeons will talk about enucleation with curettage and peripheral osteotomy. Again, terms, hopefully you are familiar with them by now. Okay? I don't have time to go into detail of that. They usually do chemical cauterization or electrocautery. The commonly used chemical cautery is Carnoy's solution. As I said, this Ameloblastoma is associated with high rate of recurrence if it is not removed adequately. If you remember the WHO 2017 definition of Ameloblastoma, they talk about this. High recurrence if not adequately surgically removed. So it requires a long-term periodic radiograph follow-up. Why? To make sure recurrence is not happening. So you have to ask once the treatment is done, once the surgery is done, patient has gone back home, but remember to instruct the patient that there is a chance of you to having an Ameloblastoma again. So please come back to me every 6 months and take an OPG or a CBCT or a radiograph to understand whether the lesion has recurred or there is any chance of recurrence. The second treatment line or surgery that can be done is what the surgeons call as segmental, that is one segment, segmental, en bloc resection or radical resection with wide surgical margins. Meaning the surgical margin should be 1 to 1.5 centimeter beyond the radiographic. Okay, you're examining the radiographic and planning the treatment, which should be 1.5 centimeter beyond the radiographic or the clinical, that which you're visualizing extent of that tumor. Why? Because if you leave any small bit of that odontogenic epithelium there, it is going to recur. It is going to come back. The patient is going to come back with again an Ameloblastoma. Not a good thing if you are a doctor. So the surgical margin should be on the rim of normal bone. This is very essential. If you are a good surgeon, you have to ensure that the margin, that bone margin, from which you cut off or resected off the tumor is completely healthy without any remnants. The third one, if it is a huge lesion, large lesion, you may have to remove the whole of the mandible. Okay, from the midline, you have to open up the whole face, open it and remove the whole bone from the midline. partial mandilectomy, or if it is a maxilla, partial maxillectomy. And of course, if you remove half of the face, half of the patient's face, quality of life of that patient is way down. So you need to reconstruct. The patient cannot walk around without half of the face, half of the maxilla is not there, half of the mandible is not there. How will the patient chew? How will the patient eat? How will the patient talk? Okay, apart from the aesthetics part, yes, all that functional part is affected. So you do what is known as reconstructive surgery, either with the fibula bone, hopefully you know where fibula is, or the rib graft. Rib is usually commonly used because it's kind of curved. So mandible is at kind of an angle. So that rib is kind of already naturally curved. So you get a contour. So rib graft is kind of accepted by the surgeons. But nowadays, okay, newer technologies have come and we have customized implants. We can make or order a titanium implant plate which can appear like the jaw, and once you remove it, the surgeon puts that titanium implant inside the jaw. Hopefully you understand what implant is and what I'm talking about is titanium implant, technique, okay? So it requires to be osteointegrated. So some other bone that is left behind, be osteointegrated so that the aesthetic and the functional part is covered. And of course, in this age and time, what we have the bioprinting, 3D bioprinting. So we can take a CBCT, the DICOM file is sent to the lab which creates bioprinting or do a bioprinting, and they print the whole good, nice jaw as such, exact match. Usually they take the opposite side and create an exact replica mirror of that and get the exact bone. So you can just remove the tumor, take this bioprinted mandible, if it's a mandible lesion, put it right back, suture it. Surgery is easy, patient is happy because aesthetics and function is maintained. So that is the treatment of ameloblastoma. Enucleation with curettage, en bloc or radical or segmental recession or partial mandilectomy or maxillectomy, depending on the size, anatomic location, histopathological variant, and the structures that is involved. So with that, it's time to say thank you and goodbye. I leave you with the Helen Keller's quotation: the best and the most beautiful thing in the world cannot be seen or even touched. They must be felt with the heart. Dil mange, always more. So, hopefully this discussion did help you to understand everything about ameloblastoma. Yes, you understood the classification of odontogenic tumor. You understood the definition, you understood the clinical features, which I talked about in different headings. Yes, synonyms, pathogenesis, age, gender, site, signs and symptoms. Then I went into radiograph, multilocular, unilocular. Yes, then histopathology. I told you that is the most important part. If you are appearing for the oral pathology question paper, university paper, 6 variants: follicular, plexiform, acanthomatous, granular cell, basal cell, desmoplastic. Also, I did talk about here, and I told you the difference. Why the older classification, WHO went and classified it separately. Now they are thinking that this is an histopathological variant of conventional and solid multicystic ameloblastoma, and so they consider it, even though the clinical feature is different, the biological behavior is different, they do consider it as a histopathological variant of ameloblastoma. And then I did end it, and this discussion with treatment. Okay? I just give you an overview. Of course, hopefully the maxillofacial surgeons will teach you in detail how to treat it and how to reconstruct it. So with that, thank you for your patient listening. Hope it was useful to you. If possible, tune in back to have a look at the other types, clinical variants of ameloblastoma. The Unicystic ameloblastoma, the extraosseous ameloblastoma, peripheral or extraosseous ameloblastoma, and the metastasizing ameloblastoma. I didn't discuss about this. If time permit, I'll come back and discuss those too. Thank you and bye. Take care. Stay safe.
Thank you, sir. That was a very enlightening session. Nothing great will be achieved without great men, and men are only great if they are determined to do so. A strong champion of Annoor educational institutions who is meticulously coherent in accounting even the minutest details with high-end determination. 21 years of entrepreneurship in education and health sciences. 21 years of experience in business and marketing field. Orator in various economic forums, skilled counselor with efficient teaching experiences, high determinations with social commitments and charity. 16 years of experience as Director and Chief Executive Officer of Annoor Dental College and Hospital. 8 years experience as Manager of Tarbiyat Educational Institutions. He was a man who was instrumental in taking Annoor Dental College and Hospital to the second best dental college in India as a part of the Oral Hygiene Day 2019. The Week magazine ranked us 22nd in India. He bagged the Best CEO Award in 2019 and the latest laurel of NAC accreditation with a B++ grade. He is none other than Mr. T.S. Binyamin sir, the Director and CEO, Annoor Dental College and Hospital. I proudly invite you, sir, for the Director's address.
Warm good morning to all. Dear Principal, Vice Principal, Students Dean, Speakers of the Day, and my dear students. I'm very much delighted to say that our team has taken an initiative, especially the Department of Oral Pathology, Annoor Dental College and Hospital, Muvatupuzha, to enrich all the third-year students across the state and orient them in such a way to achieve their best in the upcoming exams. Exam Tips 2021 is an exam-oriented learning platform for oral pathology where the students are prepared to appear with confidence for the university exams. This program is spanned over 4 weeks where most of the topics are covered in detail. More than 12 eminent senior faculties from colleges all across Kerala has been contributing to this venture. This is the first time such a program has been organized for oral pathology in Kerala. I'm happy to see the overwhelming response with more than 800 participants and registrants at a national level. I implore all participants to make use of this program and take the maximum benefit from this crash course. All the best and do well in your exams. Thank you.
Thank you, sir. Moving on to the second part of the odontogenic tumors. Participants, kindly note any queries or questions regarding any of these topics can be discussed and it can be sent to the chat box. It will be discussed later in the WhatsApp group. I'm very delighted to introduce and invite a great teacher from Annoor Dental College and Hospital, Professor Dr. Deepu George Matthew. Sir has completed his BDS and MDS from the prestigious Dr. MGR University and currently working as professor and head of the Department of Oral Pathology and Microbiology, Annoor Dental College and Hospital. He is a founder partner and supervising oral pathologist at Nirnaya Orofacial Diagnostics, which is an exclusive oral pathology diagnostic service since 2016. He is very much into research practice in the field of oral pathology, which include lymphocyte culture and cytogenetics, zebrafish human equivalent researches, tissue engineering, and many more. He has several indexed publications to his credit, and he has been invited as guest speaker in various forums. He has been honored with various awards for his exemplary works in the field of oral pathology. Sir, we are very proud and privileged to have you here, sir. Wholeheartedly, we welcome you, sir. Over to you, sir.
So good afternoon to you all. I hope I'm audible. Am I audible?
Yes, sir, you are, sir.
Yeah. So I think I think there have been an overwhelming response for this program. I think the YouTube views are more than the live participants. But I'm very happy that all the students are getting a lot of benefit out of this program that we are conducting. Now, odontogenic tumors, as Dr. Anthony has very elaborately discussed, is one of the important topics, from where you're going to get maximum number of questions. So most of the topics today that we have programmed, that is odontogenic cysts and odontogenic tumors, these are the areas from where you're going to get the maximum number of essay questions, 5 marks, short essay questions, and short notes. A lot of these things are going to come. And Dr. Anthony has very elaborately discussed about the ameloblastoma. That is the most common essay question that usually comes from this particular area, that is the odontogenic tumor. So classify odontogenic tumors and discuss in detail the clinical, radiological, and the histological features of ameloblastoma is a usual question that is being asked. When a question like that is being asked, as he rightly said, what you have to write is about the conventional ameloblastoma, or what used to be earlier described as solid/multicystic ameloblastoma. But but along with that, the other variants of ameloblastoma also needs to be discussed. Since there is a paucity of time, or there was a limitation of time in the previous session, myself will be taking care of those kind of variants of the ameloblastomas. That is actually the unicystic ameloblastomas, the peripheral ameloblastomas, and the metastasizing ameloblastoma. And I will be also dealing with some of the other odontogenic tumors that has been usually asked. When you talk about the Kerala University of Health Sciences exams, you can see that other than the ameloblastoma, the other common tumor that has been asked is the Adenomatoid odontogenic tumor, the Pindborg tumor, that's a calcifying epithelial odontogenic tumor, and odontomas are being asked. So these are, and even cementoblastomas, they are being asked. So these things can be asked as a 5 marks question, and sometimes it can be even asked as a 3 marks question. So you have to be mentally prepared for taking care of all these things, and you have to draw the diagrams. It's very, very important. Okay, so those diagrams, you cannot expect to go to the exam hall and sit there and start drawing the diagrams. It's never going to happen. You have to keep on practicing. Just like what I have told you in the first session, you should be able to finish one diagram within a 1 minute's time. So you have to keep a stopwatch with you, and you have to see how fast you are able to draw it. So you have to do that. Okay. So with this, let me start with my presentation. One minute, we just put it in the, okay. So you guys can see the PowerPoint. Can you all see the PowerPoint?
Yes, sir, we can see.
Fine. So today we're going to discuss about the odontogenic tumors, other than the conventional ameloblastoma or the solid/multicystic ameloblastoma. That's what we're going to see now. So the contents of this particular session is going to be the ameloblastoma variants, because it can be asked as a 5 marks question or as a 3 marks question, or otherwise, if you are writing an essay on ameloblastoma, it is always better if you can write 1 or 2 paragraphs on the unicystic ameloblastomas, peripheral ameloblastomas, and the metastasizing ameloblastoma. So you need to have an idea about those things. And the next one that we're going to discuss is about the Pindborg tumor. That's actually a 5 marks question. And the next one will be adenomatoid odontogenic tumor. It can be asked as a 5 marks question. And sometimes the histopathologic features alone can be asked as a 3 marks question. And odontomas, it's another important question that has been usually asked, can be asked as a 5 marks question. And if the different types of 2 types of odontomas are there, and one single type of odontoma alone can be asked as a 3 marks question. And cementoblastoma, another lesion that can be asked as again as a 3 marks question. So these are the questions that we are going to discuss in today's presentation. So when we talk about the unicystic ameloblastoma, it can be asked as a 5 marks question, or at the same time it can, like if you're writing a conventional ameloblastoma, it would be nice if you can put one paragraph on the unicystic ameloblastoma. It will give you more marks, score more marks in your ameloblastoma essay question. So what do you mean by unicystic ameloblastoma? Remember, like when Dr. Anthony was talking, like, he said something about the radiographic appearance of an ameloblastoma. So what was the radiographic appearance of a conventional or a solid/multicystic ameloblastoma? It is either a soap bubble pattern or a honeycomb pattern. So you're going to have multiple localations. Imagine a type of ameloblastoma where you're going to have a unicystic radiolucent lesion. It is going to appear as a unicystic radiolucent lesion. There is no multilocalarity. That particular type of ameloblastoma is known as a unicystic ameloblastoma. So we can say that we have to give a definition. The correct definition is actually very elaborate, very difficult for you to remember. So I just shortened it up. From an undergraduate level, this is more than enough for you to remember. So unicystic ameloblastoma can be defined as a single cystic lesion lined in some areas by ameloblastomatous epithelium. So it can be a single cystic, it should be a single cystic lesion lined in some areas. It's not necessary that all areas should be lined. At least some areas should be lined by an ameloblastomatous epithelium. So the terminology or the diagnosis of unicystic ameloblastoma comes from the macroscopic and the microscopic appearance. So what I mean from that is, when you take a radiograph, you should see it as a unilocular radiolucency. When the surgeon opens the sites and visualizes it during the surgery, it should appear like a unicystic cavity, a single cystic cavity. Even during the microscopic examination also, it should appear as a single cystic cavity. So all these things get satisfied, then only you can consider the diagnosis of it as a unicystic ameloblastoma. Now, when you look at the clinical and radiological appearance, like the average age of occurrence of this particular type of ameloblastoma is around 23 years. This is in contrast, around 10 years younger than that of what you see for a conventional ameloblastoma, which is usually 30 to 35 years. Because this type of ameloblastoma is usually seen as a pericoronal radiolucency. That is a radiolucency covering the crown of an impacted third molar. So when a patient comes and if you're taking a radiograph and you see a pericoronal radiolucency, definitely the first diagnosis that you're going to consider is going to be a dentigerous cyst. So here you can see a unicystic ameloblastoma, which actually resembles radiologically like that of a dentigerous cyst. Only when you're going to do, when you are removing it and when you're going to do a histopathological examination, then only you realize that it is not a dentigerous cyst, but it is actually a unicystic ameloblastoma. So that is why histopathology is very important. Even when you're doing the practice, like later once you pass out and go, it's very important that when you get any kind of pericoronal radiolucency in an impacted teeth, always submit it for histopathological examination, because you will never know whether you're dealing with an ordinary, very benign dentigerous cyst or an aggressive type of like ameloblastoma. So, as I told you, surgically these lesions or clinically these lesions will appear as a cyst, and the diagnosis of ameloblastoma is only made after the histopathological examination. So this emphasizes that, or this shows the importance of histopathological examination for making a proper diagnosis. Now, what are the different histological variants of this unicystic ameloblastoma? The great pathologist called Ackermann has actually classified or described the variants of the unicystic ameloblastoma. So understanding these variants are very important when you're making the diagnosis, because the prognosis for each of these variants are different. Now here, like there's a picture of a unicystic ameloblastoma where you're going to have a cystic cavity, you have a lining epithelium, then you have a connective tissue capsule around it. Now, sometimes you can see that the lining epithelium undergoes ameloblastomatous change, like what you can see with the red arrows or the red circle. When the lining epithelium itself undergoes ameloblastomatous change, you will call this type of a unicystic ameloblastoma as luminal unicystic ameloblastoma. Okay, it is called luminal unicystic ameloblastoma. Sometimes what you can see is there will be an ameloblastomatous proliferation from the lining epithelium into the lumen. Okay, into the central part, into the lumen, there will be a ameloblastomatous proliferation of the lining epithelium into the lumen. That is called intraluminal unicystic ameloblastoma. So in the second one, where we can see with the blue circle, you can see the ameloblastomatous proliferation is occurring into the lumen of the cyst. That is called intraluminal unicystic ameloblastoma. And the third variant is one in which the ameloblastomatous proliferation occurs into the capsule of the unicystic ameloblastoma. Okay, so that is the intramural. Mural means wall. So it is proliferating. The ameloblastomatous tissue or the follicles are proliferating into the connective tissue capsule, and that is called intramural. Mural means wall. So the ameloblastomas are proliferating into the walls of the unicystic ameloblastoma. So that is called the intramural type of unicystic ameloblastoma. So these are the three types of histological variants of unicystic ameloblastoma. This you have to remember. Okay. Now let's go to each of these things and explain a little bit more. So this is the, when you look at the histology of a luminal unicystic ameloblastoma, you can see there is a ameloblast-like lining epithelium. So when you have learned, like in the previous session, you have learned about what all are the cells that is involved in the ameloblastoma. You will always get ameloblast-like cells with a reversal of polarity, and above that you get always stellate reticulum-like cells. So similarly, here in the lining epithelium also, the basal cells will be ameloblast-like cells with a reversal of polarity, and the suprabasilar cells will be stellate reticulum-like cells. Okay, so that is why it's the lining epithelium is undergoing this type of change. So we call it as a luminal unicystic ameloblastoma. Now I want to show you, because I told you, like, like most of the time it is seen around the crown of an impacted teeth. So the first diagnosis that we are going to think clinically is going to be a dentigerous cyst. So this is the lining epithelium of a dentigerous cyst. But when the histology comes for a unicystic ameloblastoma, you can see that there is a stark difference in the histological appearance from that of a dentigerous cyst when it is a ameloblastomatous lining. So imagine a pathologist is sitting and, like, somebody is giving a clinical diagnosis of dentigerous cyst. The slide comes and he has to, and he's seeing something like an ameloblastomatous lining, and he has to give a diagnosis. There should be some kind of a criteria based on which he has to make the diagnosis. So what is that criteria? So around 4 features has to be there if you want to call it as a luminal unicystic ameloblastoma. Okay, so this, the first one in that criteria is the basal layer of the columnar, the basal layer of the should be columnar or cuboidal epithelium with hypochromatic nuclei. The basal cell should show reversal of polarity like an ameloblast. Basilar cytoplasmic vacuolization should be there, and the overlying epithelium should resemble like that of a stellate reticulum. This criteria has to be satisfied if you want to call a particular cyst as a luminal unicystic ameloblastoma. Okay, so this criteria is known as the Vickers and Gorlins criteria. So you have to remember about this Vickers and Gorlins criteria. Only 4 points you have to remember. Okay, basal cells are columnar or cuboidal with hypochromatic nuclei. Basal cells are showing reversal of polarity. Basilar cells are going cytoplasmic vacuolization. Overlying epithelium is going to resemble like a stellate reticulum. So these 4 points you have to remember. Now the other variant is the intraluminal unicystic ameloblastoma. All of you remember what you can see here on the picture is a cystic cavity, and you can see the ameloblastomatous epithelium. The red arrow is pointing to the ameloblastomatous epithelium proliferating into the lumen of the cyst. Okay, this is intraluminal unicystic ameloblastoma. And the third variant is the one in which the ameloblastoma tissue or the follicles or the follicles are going to proliferate into the wall of the unicystic ameloblastoma. Okay, into the wall of the capsule of the cyst. Okay, so this is known as intramural unicystic ameloblastoma. So here you can see the lining epithelium of the unicystic ameloblastoma, and then you can see that the follicles of ameloblastomatous tissues are proliferating into the the capsular spaces. So this is the intramural unicystic ameloblastoma. So when it comes to the treatment and prognosis, the treatment and prognosis is going to be based on what type of unicystic ameloblastoma it is going to be. For example, what you have to remember is for the luminal and the intraluminal unicystic ameloblastoma, that is, for only the lining epithelium is changed, and from the lining epithelium, ameloblastomatous tissues, if they are proliferating into the lumen, that is the intraluminal unicystic ameloblastoma. For them, the recurrence rate is very small. That is only 6.7%, just like any other cyst. For them, you just have to treat them in a conservative manner, just like how you are treating an odontogenic cyst. But when it comes to intramural unicystic ameloblastoma, the recurrence rate is around 35.7%, similar to that of a conventional ameloblastoma or a multicystic ameloblastoma. Because we really don't know, like even if the surgeon takes out the lesion or like removes the lesion, there is a possibility that some of these islands of odontogenic or ameloblastomatous islands can still remain in the connective tissue and can cause the recurrence. So that is why there is such a stark increase in the recurrence rate, especially in the case of an intramural unicystic ameloblastoma. So it is recommended to be treated aggressively, just like a solid/multicystic ameloblastoma. And you need to keep the patient under follow-up for a period of 10 years, because usually these recurrences are seen after 10 years. So it is important that you have to keep these patients under long-term follow-up. Okay, so that is basically the unicystic ameloblastomas. And let's see like how you have to write an answer if a question comes for a 5 marks for a unicystic ameloblastoma. So you don't have to write a full essay like kind of thing, spanning for 1 page or half page. You have to concise your answer for a 5 marks question. And you can give a small introduction. You can talk about an average age, and you just have to talk about the well-defined radiolucency, and the crown of an unerupted third molar is an important point. You have to underline that. And clinically, it can resemble like a Dentigerous cyst also, you can underline. Then you talk about the 3 variants of the unicystic ameloblastoma. Give a small description, a 1-line description for each variant. And under luminal unicystic ameloblastoma, you can write the 4 points of the Vickers and Gorlins criteria. And if time permits, you can just draw a pencil diagram on that particular picture, wherein which you can show all the 3 patterns of unicystic ameloblastomas. And again, you can just give a small 2 points for the treatment part. And this is how you have to present a paper for a 5 marks question. So the next one is going to be the peripheral ameloblastoma. So remember, this peripheral ameloblastoma doesn't have anything to do with the bone. Okay, it is not inside the bone, it's outside the bone. So it occurs in the soft tissues overlying the tooth-bearing areas of the maxilla and mandible. So it does not invade the underlying bone. Okay, and it usually occurs as a painless and exophytic mass. And the origin is considered to be either from the cell rest of serrae. So what is cell rest of serrae? It is actually the remnants of the dental lamina, okay, which is seen in the gingiva. Or like some people even say that they arise from the basal cells of the surface epithelium. So the mean age is around 52. So the age is entirely different in the case of peripheral ameloblastomas. And the mandible is more affected than that of the maxilla. And the common location for the mandible is the premolar area. For the maxilla, it is the parietal area near to the tuberosity. So here you can see an example in the picture of a peripheral ameloblastoma on the palate. Histopathology, you're going to see just beneath the epithelium, like islands and strands of ameloblastomatous epithelium. Okay, treatment is local surgical excision. Recurrence is very less, only 15%, and the patient is going to have a good prognosis in the case of a peripheral ameloblastoma. Now, how are you going to write the answer for this? How are you going to frame the answer? Because it can be asked like not very frequently, but you can actually put it as a small part in your ameloblastoma essay part once you finish with your conventional ameloblastoma. So you can just write like 3-4 points for this particular question if it's asked as a 3 marks question, or you can put this 4 points underneath your conventional ameloblastoma with the heading of peripheral ameloblastoma, so that there will be a completion for your essay. So when you are writing it, like underline, it is there in the soft tissues in the tooth-bearing areas. And then underline the next point that it does not invade the underlying bone. And what is the tissue of origin from where, or the origin from or the tissue from where the particular lesion is originating. That's the cell rest of serrae. Okay, so these points you can underline and you can frame your answers. The next one is the variant of ameloblastoma is the malignant ameloblastoma, or known as the metastasizing ameloblastoma. So it can be asked as a 3 marks question, or you can put it underneath your conventional ameloblastoma essay. Now, even though it has got the name malignant ameloblastoma or metastasizing ameloblastoma, we know that metastasis is a feature of a malignancy. In the 2017, the recent 2017 WHO classification, this earlier it was classified under carcinomas, but now after the 2017 classification, from the carcinoma section, it has been transferred, or it's been taken and put under the benign category. Okay, we will come to why it is now considered as a benign one. Even though some controversy still exists about its inclusion under the benign category, it is now from 2017 onwards in the WHO classification for odontogenic tumors, it is classified under the benign category. So these are considered, you know that ameloblastomas are basically benign tumors. But 2% of these ameloblastomas can show metastasis to distant sites. The common sites for metastasis are the lungs and the lymph nodes. But why this metastasizing ameloblastoma is considered under the benign category? The reason is both primary and the metastasis outgrowths are histologically benign ameloblastoma tissue. Okay, because we have learned in your epithelial pathology and all those things, we have seen that whenever there is a malignancy, what you're going to see is cytological atypia. So what are the features of cytological atypia? Increased nuclear cytoplasmic ratio, nuclear hyperchromatism, cellular and nuclear pleomorphism, all those things are the what do you call the atypical features, cytological atypical features, which will tell you that what you're looking, the tissue that you're looking onto is actually a malignant one. But here in the metastasizing ameloblastoma, both the primary and the metastatic growths will not show any features of cytological atypia. So that is one of the reasons why now this particular type of ameloblastoma, that is the metastasizing ameloblastoma or the malignant ameloblastoma, is categorized under the benign category. So even though the name suggests it is something of a malignancy, but actually it is now classified under the benign category. So when you look at the clinical features, this is usually average age of presentation is around 30 years. More male predilection is seen, and one of the predisposing factors which causes this metastasizing ameloblastoma is the history of multiple recurrences of ameloblastoma and the associated surgeries. Maybe the associated like multiple surgeries may be the reason why this tumor would have spread or would have seeded through the blood vessels and would have reached to the lungs. Okay, so the spread is basically considered to be through the hematogenous route. So treatment, you have to go for a radical surgery for the primary, and if adequate pulmonary function can be preserved, lobectomy of the affected lungs can be performed. But after the diagnosis of metastasis, the median survival period for the patient is supposed to be very small, like it's supposed to be 3 months to 5 years. So if you're writing a small short note for malignant ameloblastoma or metastasizing ameloblastoma, this is how you can frame your answer. And you just have to write 3-4 points into it. Like you don't have to spend too much time on it because you should whatever you write, like going to get 1.5 marks or 2 marks. So if you write it very well, you're going to get 2 marks. So what you have to do is you have to underline the important parts. One is important point that you have to underline is the metastasis into distant site. What are the common site? Lungs and lymph nodes. And the most important point that you have to emphasize and underline is histologically benign ameloblastoma tissue with no cytological atypia. That is the important point that you have to underline. Okay, and the spread is basically through the hematogenous route. So if you can underline these points and if you can frame an answer, you're going to score maximum marks for this particular question. Now, since we have talked about the variants of ameloblastoma, let me go to another type of tumor, odontogenic tumor, that is ameloblastic carcinoma. So in contrast to metastasizing ameloblastoma, ameloblastic carcinoma is a real malignancy, odontogenic malignancy or odontogenic carcinoma. So this is not classified under the benign category. This is a tumor which is categorized under the odontogenic carcinomas. Okay, so this is an ameloblastoma with histological evidence of malignancy. Remember, metastasizing ameloblastoma or malignant ameloblastoma didn't have any histological evidences of malignancy. But here in ameloblastic carcinoma, you're going to see histological evidences of malignancy like nuclear enlargement, nuclear hyperchromatism, increased nuclear cytoplasmic ratio, abnormal mitotic figures, and increased mitotic activity. So all these cytological atypical features you will be able to visualize. Then you're going to call it as an ameloblastic carcinoma. So there are 2 types of ameloblastic carcinomas. Either it can be a carcinoma ex ameloblastoma. That is, initially it would have started as a benign ameloblastoma. Later, this would have transformed later during the recurrences. This ameloblastoma would have transformed into a malignant one. That is a dedifferentiation over time. So that dedifferentiation is an important point. Otherwise, the other possibility is the beginning itself, the time when you're diagnosing itself, it will be a ameloblastoma with malignant features or like with cytological atypia, then we call it as a de novo ameloblastic carcinoma. So you can have two types of ameloblastic carcinomas, carcinoma ex ameloblastoma or de novo ameloblastic carcinoma. So here again, radical surgery is the mode of treatment. So it can have metastasis or may not have metastasis. So metastasis is not an important point here. It can have metastasis or may not have metastasis. The main important difference between a metastasizing ameloblastoma and an ameloblastic carcinoma is the presence or absence of cytological atypia. In metastasizing ameloblastoma, you may have metastasis but no cytological atypia. In ameloblastic carcinoma, you may or may not have metastasis, but you should have cytological atypia to make a diagnosis of ameloblastic carcinoma. So with this, all these ameloblastomas and all those variants of ameloblastomas are over. Now we are coming into another interesting tumor that is often been asked, like, even though it is only 1% of all the odontogenic tumors, it is after ameloblastoma, this is the most favorite question for any examiner, even if it's your theory exam or if it is in your practical viva questions, because maybe it is because of its special name called the Pindborg tumor. So this was first described by Pindborg, who was a very famous orthopathologist, and he initially described it as a separate entity. So the histogenesis of this particular tumor is uncertain, but it is considered that either it is arising from a stratum intermedium or the remnants of the dental laminae, that is the cellus of Ceres. Now, when we come into the clinical features, it has got a lot of resemblance or overlapping in its clinical features with that of our ameloblastoma. Okay, so the age is also of occurrence is also almost the same, like around 30 to 50 years of age. The site is mandibular posterior region, just like our conventional ameloblastoma, but a little bit more anterior. Usually it presents as a painless, slow-growing swelling. And what is interesting is around 12% of these cases can be seen associated with an impacted teeth, usually a mandibular third molars. Now, radiographic features is a very important thing in that when it comes to the Pindborg tumor or the calcifying epithelial odontogenic tumor. From the name of this particular tumor itself, you know that there is calcifications within the lesion. So when you have calcifications and when you're taking a radiograph, what you're going to see is you're going to see white specks within the radiolucency. And this calcification, so here you can see in the radiograph, the CT image over here, a lesion, a Pindborg tumor which is growing, and you can see the calcifications within the radiolucency. So this is given a special name called the driven snow appearance, just like the white snowflakes are falling down. So it is called the driven snow appearance. Okay, so this is a favorite question when it comes to a viva. At the same time, like if a question of Pindborg tumors is being asked as your short essay or a 5 marks question, the evaluator will expect to see driven snow appearance in your radiological features. So you should underline that. Once he sees that, like immediately, he will immediately give marks and go. Okay, so it can present as a unilocular or a multilocular radiolucency, this particular radiograph of a Pindborg tumor. Now, histology is very interesting. So you should not get too much worried about histology. It's a very simple thing. If you can properly understand it, it's very easy for you to understand the histology. Okay. Now, for many students, when they talk about histology, they are all so scared and because they really don't understand the histology. So let us try to make it as simple as possible. Okay. Now, when you're looking here, you can see discrete islands, strands, or sheets of polyhedral cells. So I'm putting my blue arrows there where you can see islands, strands, or sheets of polyhedral epithelial cells. So these are epithelial cells in a fibrous connective tissue. So I think it's pretty easy for any of you to understand. You can see the strands and sheets of these cells within a fibrous connective tissue. Now, I want you to have a closer look at these cells. Now, this is how these cells are going to look like. If you look at the outline, I told you it's a polyhedral or a polygonal cell, like many-sided cell. Let us see, trace the outline of these cells and see how they are polygonal. So I'm tracing the outline of one of those cells, and you can see that black dotted lines, that it is a many-sided cell. So that is what I told you, it is a polygonal or a polyhedral cell. Okay. Now, you can see that the cell outlines are very distinct, and you can even make out the desmosomes. You can see the yellow arrows are pointing to the borders of these cells, and you can easily make out the even the small spiny projections of the desmosomal junctions between the epithelial cells. Now, another interesting feature of a Pindborg's tumor is the presence of nuclear pleomorphism. What do you mean by pleomorphism? The variation in the shape is known as pleomorphism. This is an important feature of cytological atypia, which indicates malignancy. But here, there's an exception in the case of a Pindborg's tumor. Pindborg's tumor, you will see cytological or like nuclear pleomorphism, okay, or variation in the size or the shape of the nucleus. Here you can see all the red arrows are pointing to these nuclei, which are having varying shapes. Okay, even though they have nuclear pleomorphism, still Pindborg's tumor is a benign condition or a benign tumor. So this is an exception where you get nuclear pleomorphism in a benign lesion. Okay, so don't, just because you saw like nuclear pleomorphism, you know, pathologists should not confuse this as a malignancy. Okay, this is an exception where you can, in a benign lesion, where you can see nuclear pleomorphism. Another interesting feature is this strands of epithelial or the epithelial tumor cells are going to produce amorphous eosinophilic hyalinized amyloid-like extracellular material. These epithelial cells are going to secrete something. The tumor cells are secreting something. So here you can see the red arrows are all pointing to the tumor islands and the strands. And near to these tumor islands and strands in the connective tissue, you can see the blue arrows are pointing to an eosinophilic hyalinized amyloid-like extracellular material. Okay, so when you do a special stain for it, if you are suspecting that it is an amyloid, what is a special stain that you can do? You can do something known as a Congo red. And once you do the Congo red, and if you observe it under a polarizing microscope, you will be able to see apple green birefringence. So you can see the apple green birefringence in the amyloids that has been deposited in the connective tissue in a Pindborg's tumor. Now, another important feature is the areas where these amyloids have been deposited. In those areas, calcification can happen. And you may see concentric rings. So here you can see the calcifications. And if you look at where the red circles are there, and if you look carefully within these calcifications, you can see concentric rings within these calcifications. That is known as Lesigang rings. That is known as the Lesigang rings. It's an important, again, another important point that the evaluator will expect from your answer. So the treatment is less aggressive than that of an ameloblastoma. Conservative local resection with the margin of normal bone recurrence rate is around 15%. It's got a better prognosis than that of the ameloblastoma. So how are you going to write an answer if a question is being asked as the Pindborg's tumor or the calcifying epithelial odontogenic tumor? You have to give a small introduction or the one line introduction. You can talk about a histogenesis. Then you give a small description on the clinical features, the site, the age, and like how it is growing. When it comes to the radiological features, remember you have to write it as a multilocular or a unilocular radiolucency. The snow-driven appearance has to be underlined. Histopathology is very important. You talk about the polyhedral cells, the shape of the cell, talk about the nuclear pleomorphism, talk about the amyloid deposits, and definitely underline the Lesigang rings. Okay. So that's all about the Pindborg's tumor or the calcifying epithelial odontogenic tumor. The next interesting tumor or the important tumor that you have to discuss is the Adenomatoid odontogenic tumor. So around 3 to 7% of all odontogenic tumors are adenomatoid odontogenic tumors, or sometimes we'll call it as AOTs. So usually this is supposed to be arising from the rest of the serrae, cell rest of serrae, or some other components of the enamel organ. And they don't have much growth potential. Adenomatoid odontogenic tumors may not have much growth potential. So that is why many researchers consider it as a hamartoma or like not a real neoplasm. The mean age of occurrence is around 18 years. Around 73% of these patients are below the age of 20 years. And you can see a female predilection in the case of adenomatoid odontogenic tumors. So this tumor is seen more commonly in the maxilla than that of the mandible. So in contrast to ameloblastoma and Pindborg's tumor that we had discussed till now, this tumor is seen more commonly in the case of maxilla than in the case of mandible. And it is seen more in the anterior parts of the jaw rather than the posterior parts of the jaw. And 76% of these tumors will develop anterior to the canine areas. So here you can see the clinical picture, a small growth that is there on the canine region in the maxilla. Now, and the interesting point here is 74% of these lesions are associated with the crowns of an unerupted teeth. Which unerupted teeth? 2/3 of these cases are associated with the maxillary impacted canine. Most of them are associated with the maxillary impacted canine. Okay, so unicystic ameloblastomas are seen commonly with an impacted mandibular third molar. Adenomatoid odontogenic tumors are seen more commonly with maxillary impacted canines. The average size is around 1.5 to 3 centimeters and usually presents as a painless swelling. Now here is a radiographic appearance of the adenomatoid odontogenic tumor. If you see here in the radiograph, it's a part of an OPG. You can see an impacted canine with a pericoronal radiolucency. Okay, and if you look at this radiolucency, like there is a way in which you can differentiate from the radiograph itself, whether it is a dentigerous cyst. Sometimes you can have an impacted canine and you can have a dentigerous cyst with a similar appearance, or like, you know, so how are you going to differentiate? Is there any way in which you can differentiate between dentigerous cyst associated with an impacted canine with that of adenomatoid odontogenic tumor? So if you look here, like the tumor, the radiolucency is extending beyond the cemento-enamel junction. The red arrow is pointing to the cemento-enamel junction, and you can see the pericoronal radiolucency is extending beyond the cemento-enamel junction, which is usually seen in the case of a tumor rather than a dentigerous cyst. If for a dentigerous cyst, usually that cyst lining or the radiolucency will be like, you know, attached to the neck of the teeth, that is the cemento-enamel junction. So here you can see that the radiolucency is extending beyond the cemento-enamel junction. So from the radiograph itself, you can make an assessment that this can be a adenomatoid odontogenic tumor. So sometimes you can get the radiographic appearance as a unilocular radiolucency without any impacted teeth. And some of these radiolucencies usually present with specks of calcification. So here you can see a lesion, which is a unilocular radiolucency. And within this lesion, you can see, like, you know, specks of calcification. So when it comes to the histology of adenomatoid odontogenic tumor, often the students will be very much like, you know, confused, like how to write the answer for this particular histology. They don't get their head around like the histological features. Now, I'm trying to make it much more simpler for you. So here, like, it's a picture of adenomatoid odontogenic tumor with all the various patterns. So here you can see a proliferation of spindle-shaped cells. So basically what you're going to see is majority of the cells in an AOT is going to be spindle-shaped cells. So the red arrows are pointing to the streaming fascicles of the spindle-shaped cells. Along with that, and sometimes you can see that some of these spindle-shaped cells will form into a wall-like manner. It will just get walled around and form like a menace-like areas can be seen. The spindle-shaped cells can just go around and form a wall like that. And you will also see cuboidal or columnar cells. What are these cuboidal or columnar cells? These cuboidal or columnar cells can form into duct-like spaces. So now you understood why we call it as an adenomatoid odontogenic tumor. Even though this is it's an odontogenic tumor, still you are seeing some amount of ductal differentiation, which you usually see in the case of a salivary gland tumor. But this is not a salivary gland tumor. This is an odontogenic tumor, which is showing some amount of ductal differentiation. Okay, so you may think why this is happening, why an odontogenic tumor is showing ductal differentiation. You should remember that both the salivary gland tissues and the odontogenic tissues are all formed from the surface epithelium. The origin is same for both these type of tissues. Maybe like during when they are undergoing neoplastic transformation, some mutations are occurring and they are taking some features of that ductal differentiation. Okay, another interesting feature that you are seeing here is the presence of rosettes. You can see here the blue circle is showing the cuboidal cells forming into rosettes. We will come to those things much more elaborately in the coming slides. So here is a duct-like structure. I'm just focusing more on those ducts now. You can see the duct over here. The red circle is putting focusing on the ductal areas. So you can see it is formed of a single layer of cuboidal or columnar cells. You can easily make out that cuboidal or columnar cells. And what is interesting is if you look at the nucleus is away from the lumen. Okay, they are polarized away from the lumen. That is an interesting feature in the case of a duct in an adenomatoid odontogenic tumor. And within the lumen, you get an eosinophilic line or eosinophilic rim can be seen. The blue arrow is pointing to the ductal lumen where you can see an eosinophilic ring. This eosinophilic rim is known as hyaline rim. This is called as the hyaline ring. Okay, so these are the important points that you have to remember in the histology. The presence of ductal areas, spindle-shaped cells, then the ductal differentiation formed by the cuboidal or columnar cells, the nucleus polarized away from the lumen, an eosinophilic rim known as hyaline ring. So these are the important points that you have to highlight in your answers. Now, let us talk about that rosette formation. Some of these epithelial cells or the cuboidal cells or columnar cells will form into rosettes. So this is a rosette that you can see here. Now, you don't have a lumen for that. The central space can be, the space may be empty or can contain a eosinophilic material. So here the blue arrow is pointing to a eosinophilic material in the middle of the rosette. You can also see some amount of calcification in few of these cysts. So this is a foci of calcification in an adenomatoid odontogenic tumor. So the treatment is conservative treatment. It is not going to recur, and you can just do an enucleation because it usually will have a presence of a capsule will be there. It's an encapsulated tumor. So if you're writing an answer, this is how you have to frame your answer. You can write a small description on your introduction. You talk about the clinical features, underline that it's usually seen around the crowns of unerupted teeth and associated with the maxillary canine. And you have to the histological, and you have to histology, you have to underline that duct-like structures are seen, the nuclei polarized away from the lumen, hyaline ring, rosette-like formation. All these things you have to underline, and you have to draw a diagram also. Okay, so even for Pindborg's tumor and for Adenomatoid odontogenic tumor, when it's been asked as a 5 marks question, you have to draw a diagram. Now we are coming to the next division, that is the odontomes. Okay, so this is a particular tumor that we have categorized under the second category of the benign tumors, that is of mixed origin. So this particular tumor has the contribution from both ectoderm and the ectomesenchyme or the mesenchymal part, ectomesenchymal part, and their tissue products. So we have the epithelial and the ectomesenchymal components. They appear normal, but they don't have a proper structural arrangement. So what it means by that is they are going to produce the ectodermal product. What is the ectodermal product in the tooth development? It is the enamel. What are the ectomesenchymal products during tooth development? The dentine, pulp, and the cementum. These are the ectomesenchymal products. You're going to see enamel, dentine, pulp, cementum, all these things you're going to see in odontomas. But the only problem is that they are not going to be arranged in the correct way as you see in the case of a teeth. In a teeth, you will see enamel first, then beneath that you're going to have dentine, and covering the root dentine, you're going to have the cementum. You're not going to have such an organized arrangement in the case of a odontoma. Okay, so that is why many people consider it even as a hamartoma or just as a developmental anomaly. This is considered to be one of the commonest odontogenic tumors in So there are two types of odontomas. The first one is complex odontoma and the other one is compound odontomas. So let's talk about the complex odontomas first. Complex odontomas, just like the name indicates, it is a little bit complicated type. Okay, so it is a self-limiting developmental anomaly. It is going to grow and it is going to stop growing after some time. And what you're going to see is a ball or a mass of enamel, dentine, and the other pulp and a cementum. Okay, it is going to look like a ball. It's a conglomerate mass of enamel and dentine with some amount of pulp and cementum. And it has got no morphological resemblance to that of a normal teeth. Okay, so that is why it is called complex odontome. See, he is not very simple. He doesn't look like a normal teeth. He is going to be just a complex mixture of enamel, dentine, pulp, and cementum. So the mean age of occurrence is around 19 years, and the common site for occurrence is the posterior mandible region. Okay, this you have to remember. We'll come to that. Now, it usually presents as a slow-growing, expanding, painless lesion, often detected in the routine radiographs, and the size can vary from 3 to 4 centimeters, and the adjacent teeth may fail to erupt. Now, when you look at the radiograph, here you can see it usually presents as a radio-opaque mass, and you will not see that there is any resemblance to that of a teeth. And your radiopaque mass, and usually you will see it is surrounded by a narrow radiolucent rim. Okay, you can see some amount of radiolucency around the radioopacity. This is another larger lesion, which more bigger radiopaque mass was there. So histopathology, you can say that there is a disordered mixture of dental tissues, often spherical in nature, and it consists of mainly mature dentine. You get empty areas which contain mature enamel. Why it is empty? It is because you do, when you want to make sections, you have, since it's a hard tissue material is there, you have to do decalcification. So if mature dentine is there, that will be removed, and the area where the dentine was occupying will appear as a vacant or a hollow area. Okay. You can see some amount of cementum and pulp. Varying amounts of proliferating epithelium and ectomesenchyme can be seen. And not only that, another important point is you can sometimes see ghost cells also. Now, let me tell you something. When we talk about ghost cells, remember you have to prepare a small short note on ghost cells. That can be asked as a 3-mark question. So you have to first say what is a ghost cell. Okay, ghost cell is abnormal, it is a kind of epithelial cell where you're going to see that it is eosinophilic cells and the nucleus is gone. You will only see the outline of the nucleus. That is why it is known as the ghost cell. And it is occurring as a result of an abnormal characterization, or it can be because of a degenerating or degenerative changes seen in the epithelium. Which all are the lesions where you will see ghost cells? You can see them in calcifying odontogenic cyst. You can see them in odontomas. You can see them in ameloblastic fibroodontomas, and you can even see them in some of the ameloblastomas. So this much you have to write if somebody asks you a question about ghost cells. Now here is a histologic picture of a complex odontoma. You can see the blue arrow is pointing to the areas of dentine. You can see the red arrows pointing to the areas of vacant spaces. That is where the enamel used to be there before the decalcification. Then you can see some areas, the black arrows are pointing to the areas where pulp tissue is there. Okay, so this is the histology of a complex odontoma. Doesn't have any resemblance to that of a teeth. You can do a conservative enucleation and recurrence is not reported. You've got a very good prognosis in the case of a complex odontoma. Next one is a compound odontoma. In the case of a compound odontoma, has got some similarity to that of a teeth. So it is like, this lesion is usually seen. So it's entirely different that of a complex odontoma. Complex odontoma is usually seen as a calcified, ball-like structure. While compound odontoma, you can see that it looks like a small, tiny, miniature shaped teeth-like structures. Okay, so it's often referred as even denticles. So the mean age is around 17 years, much a little bit younger than that of your complex odontomas. The site is another interesting feature. If you see complex odontomas more common in the posterior mandible, you will see compound odontomas more commonly in the anterior maxilla. Usually presents as a painless, benign lesion with limited growth potential than the complex odontomas. Usually the growth will end once the tooth forming period is over. That's around by 12 years, 17 years, the third molar is formed. By the time the possibility for this compound odontomas are also come down. This can be sometimes seen along with Gardner's syndrome. So usually what we see is you see a radiopaque mass of varying sizes. Here you can see a radiograph of a compound odontoma. If you look carefully, you'll be able to see that it's actually formed of radiopaque miniature tooth-like structures. So when you take it out, you will see small tooth-like structures can be seen where you see more orderly arrangement of enamel, dentine, pulp, and cementum. You will see enamel outside. Beneath that, you get dentine, and inside you get pulpal cavity and with some cemental covering in some areas. So it resembles more like a tooth-like structures, more organized than that of a complex odontoma. Okay, that is why it is called compound odontoma. So the treatment is conservative enucleation, and all denticles should be removed. If you leave some of these tooth-like structures back there, there is a probability for recurrence. So what you have to do is, after you remove all this stuff, you take another radiograph and make sure none of those things are left behind in the patient. Okay. So if you're writing an answer, usually odontomas can be asked as a 5 marks question, one of the common questions that can be asked. So other than ameloblastoma, remember the most three commonly asked questions is Pindborg's tumor, Adenomatoid odontogenic tumor, and the other one is odontomas. So you have to remember this. Okay, so you have to underline that it is actually formed from the introduction. You have to underline that ectodermal and ectomesenchymal components are there, and it's a defect in the structural arrangement. Is that what has to be underlined? Then you say that there are two types of odontomas. That is a complex odontomas and the compound odontomas. Then if you are writing only about complex odontoma, you say that can be considered as a dental anomaly, developmental anomaly. Posterior mandible is a common site, seen as an opaque mass in the mass with radio density similar to that of a tooth structure. Histology, you're going to see mature dentine, enamel spaces, cementum, and pulp tissues can be seen. And ghost cells are also present. So that also you have to underline. And when you talk about compound odontoma, you underline the part that it has got anatomic similarity to that of teeth, and the site, that is the anterior maxilla. And that another important point that you have to underline that I have not underlined here is the Gardner syndrome, association with the Gardner syndrome. And the histology, you underline the part that all dental tissues are represented more orderly pattern, so that you can mention. Okay, so sometimes complex odontoma or compound odontoma can be alone asked as a 3 marks question also. So depending upon how the question is being asked, you have to frame your answers. Now I'm coming to the last part, the last lesion in this session, that is the benign cementoblastoma. Very rarely they can ask this question. Okay, and another question which I'm not discussing today is odontogenic myxoma. Just go through it. It's got a very similar clinical features that are like that of ameloblastoma, so that you have to go a little bit. Okay, so here in benign cementoblastoma, it is a benign odontogenic tumor of ectomesenchymal origin. So what we saw in odontoma is actually a mixed tumor where both odontogenic epithelium and ectomesenchyme was there, and its products were there. While benign cementoblastoma is a tumor formed exclusively from the ectomesenchyme, because we know that it is actually a true tumor of cemental origin. It is the only true neoplasm of cemental origin, and it is characterized by the proliferation of cellular cementum. And what if you leave the lesion over there and if you are not going to treat it? What you need to remember is that it is a true neoplasm. So this neoplasm, if you leave it over there, it is going to keep on growing. It has got an unlimited growth potential. The growth rate is to the rate of around 0.5 centimeters per year. It's a benign lesion, but it can keep on growing throughout the life. So you need to remove it surgically. Most of these cases are diagnosed before the age of 30 years. And the male to female ratio is around 1:1.2. A more female predilection is seen. In the case of mandibular premolar, it is the most common site for occurrence. And if it is occurring in the maxilla, it is again the premolar area. Okay. It is, as I told you, this is actually a tumor from the cementum. So where is the cementum in the tooth? It is on the root. So this lesion is going to be intimately associated with the tooth root. And it presents as a slow growing unilateral swelling with the expansion of the affected bone. And since they are attached to the root of the teeth, especially in the periapical region, it is usually associated with pain and paresthesia because of the impingement on the nerve. And usually the pain is characterized as a toothache arising from the pulp, because it is very close to the periapical region where the nerves are going inside, and it will present as a toothache. But if you do a tooth vitality, you will see that the tooth is whiter also. So it has been seen that this tumor can actually invade into the root canals. So here is a radiographic appearance of how this cementoblastoma is going to appear. You will see that the cementoblastoma, if it is there, it is going to be seen fused to the root of the teeth. That is the pathognomonic feature for the diagnosis of a cementoblastoma. So you don't have to go for a histopathology with the radiograph itself. You can make the final diagnosis that it is a cementoblastoma. One of the differential diagnoses that you have to consider in the radiology is the condensing osteitis, which is actually a localized chronic osteomyelitis. But there we are going to see that there is a space in condensing osteitis. There is going to be a space between the tooth and the radio opaque mass. But when it comes to cementoblastoma, you will see that the radio opaque mass is attached to the root of the teeth. And you will see that the periodontal ligamental space is, or the radiolucency of the periodontal ligamental space is like, can be traced from the tooth into the cementoblastoma, and you can see that the periodontal ligamental space or the radiolucency can be traced around the cementoblastoma also. So radiography is very pathognomonic. So there is 3 stages for the development of the tumor. First, you're going to see a periapical osteolysis. Next, you're going to see that the cementoblasts are going to proliferate. Then the 3rd stage, you're going to see that the cementoblasts are going to produce more amount of cementum, and it is going to undergo calcification. So this is a tooth which is got, which has had a cementoblastoma, which is extracted. When you look at the histology, very easily you can describe the histology. You're going to see sheets of cementum-like tissues. And you're going to see that the trabeculae are lined by plumb active cementoblast. So only 2 points you have to remember. If it is a cementoblastoma, sheets of cementum. And what is going to produce a cementum? It is a cementoblast. So you talk about the plumb active cementoblast, which is lining the trabeculae of the cementum. Okay, with that, the histology is over. So surgical removal, and if you don't do a proper removal, you can have recurrences. So if you're writing a small answer for it, you can just note down this. You can, all these points can be included and put into an answer. Main thing is proliferation of cellular cementum has to be underlined. The growth rate of around 0.5 centimeter per year has to be underlined, and the radiological feature where in which the round mass fused to the root has to be underlined, and the histology, sheets of cementum-like tissues has to be underlined. So this is my team here at the Department of Oropathology at Annoor Dental College. I'm very thankful for them, for the constant support that they're giving me. And the other lesions that you have to remember is one I told you about Bose cells that you have to remember, that has been even mentioned in the odontogenic cyst part also. Yeah, another lesion that you have to keep it in your mind is the odontogenic myxoma, very similar to that of Ameloblastoma, multilocular radiolucency. But when you take it out, you have a myxomatous tissue with a glistening tissue will be there, very high recurrence rate. So that you have to prepare for a 5 marks or a 3 marks question. Sometimes people can ask, during exams, they can ask about odontogenic myxomas. So thank you so much for your patient listening. I hope all of you have benefiting a lot from this. Even though many people are not there in the, the Zoom, a lot of people are attending and seeing the videos in the YouTube. So we're very happy about the response that is happening. Okay. So thank you so much.
Thank you, sir, for this fruitful session. This was, in fact, a very fruitful session. Sir has explained all the topics in an exam-oriented manner, as if it will be beneficial for the students, as of how to write in the exams also. Thank you, sir. We are so happy to have you. And we are moving on to the next topic. Up next is a very important topic about the mesenchymal tumors, and this will be dealt by Dr. Lakshmi Priya ma'am. She was the former professor and head of the Department of Oral Pathology and Microbiology at LSA Dental College, Thodupuzha, Kerala. She has more than 13 years of teaching experience, and she finished her undergraduation and post-graduation from the prestigious Dr. MGR Medical University, Chennai. She has many national and international publications to her credit. Ma'am is currently working as a consultant oral pathologist at Nirnaya Orofacial Diagnostics, Muvatupuzha. Welcome you, ma'am, for the session. Over to you, ma'am.
A very good morning to one and all. First of all, I'd like to congratulate Annoor Dental College for organizing such a wonderful program, and I'm very glad to be a part of this program. So thank you for giving me this opportunity. And the topic that is given to me is non-epithelial tumors or mesenchymal tumors or connective tissue tumors. And I'm sure in the last class you had your epithelial lesions covered. So we'll go to the topic today. You know that in the body we have 4 types of tissues, right? Epithelium, connective tissue, nerve, and muscle. Okay. And in each of these tissues, you can have benign tumors developing and malignant tumors developing. So, we have benign category of tumors and malignant category of tumors. Okay, so in this tabular column, you see the 4 tissues and what are the benign lesions and malignant lesions in each of the tissues. So epithelium is covered for you, so we're not going to see the epithelial lesions. And the next is the mesenchymal part, or the mesenchymal tumors, that is connective tissue, nerve and muscle tumors. So you know that if anything ends with an oma, it is a benign tumor. Okay, suppose you have a short note, lipoma. So you should write whether it's benign or malignant first correctly. Then you should tell about what cell is proliferating. So it is a proliferating cell is the adipocyte or fat cells. Okay, so introduction line should be very correct. Make sure you write whether it's benign or malignant correctly, and then what kind of cell is proliferating. Okay, so if it's a lipoma, the malignant counterpart will be called as liposarcoma. An epithelial malignancy, you add carcinoma to it, and malignancy of the connective tissue or mesenchyme, you add sarcoma to it. That concept should be very clear. Okay, what is that tumor, benign or malignant, and what is the cell that is proliferating? Okay, whether it is adipocytes or is it fibroblasts or it is chondroblasts. Okay, so whatever cell is proliferating, that should be correctly written, because frequently we see in the answer papers, students mix up benign and malignant lesions, and the cell proliferating cell is completely different. Okay, so make sure your introductory line is very correct. Okay, whatever you write underneath, even if it's correct also, the whole answer will be wrong. If you introduce a lesion wrongly as you introduce a benign lesion as a malignant lesion, the whole answer becomes wrong. Okay, so all these tumors mentioned in this tabular column, make sure you prepare for a 3 marks question. Okay, any of these tumors can be asked. So you see the name, you see whether it's benign or malignant, and see what kind of cell is proliferating, add 2 or 3 points to it. Okay, so make sure you prepare the 3 marks questions for all of the lesions mentioned in this tabular column. Okay, so the first lesion we are seeing today, that's Hodgkin's lymphoma. Okay, so before going into the 5 marks question, Hodgkin's lymphoma, we'll see what lymphoma is. Okay, so I said in the previous slide that oma, if it ends, you think it's a benign lesion, right? That is a usual thing. Okay, oma, it's a benign lesion, but there is an exception. Lymphoma is a malignant lesion. Okay, there is no benign lymphoma. Keep that in mind. Be clear. Lymphoma is a malignancy. There is no such thing called as a benign lymphoma. So this is an exception. Okay, so not all omas are benign. Lymphoma is a malignant lesion. Okay, so lymphomas are a group of malignancies derived from cells of what is cell proliferating lymphoid tissue, and it can be in any of the developmental stages. Okay, which means that your B cells and lymphoid tissue means B cells and T cells. Okay, and the B cells and T cells are not in their mature stage in the beginning itself. They undergo a series of maturation. Okay, so the tumors can be either of precursor B cell or precursor T cell or mature B cell or mature T cell. Any of the cell can be mutated and form a tumor. That is your lymphoma. And how does it present? It presents as localized proliferation in the nodes or in the extranodal tissues. So the first, you have 2 major categories of lymphoma, the non-Hodgkin's lymphoma and the Hodgkin's lymphoma. Okay, non-Hodgkin's means it involves the nodes and extranodes primarily, and Hodgkin's lymphoma involves the primarily the lymph nodes. Okay, and non-Hodgkin's lymphoma doesn't have an orderly spread, whereas Hodgkin's lymphoma has an orderly spread from one group of lymph nodes to the other. So it is very important that you stage the Hodgkin's lymphoma. You give the staging for Hodgkin's lymphoma, because the stage 1, the initial stages of Hodgkin's lymphoma have a better prognosis. Now, this is your 5 marks question, Hodgkin's lymphoma. So you know that lymphoma, it is not a benign lesion, it is a malignant lesion. So introduce the first line as it is a malignant neoplasm. What cells are proliferating? Lymphoid cells of lymphoid origin. Okay, so underline that, malignant neoplasm of lymphoid origin. Who described it? It was described by Thomas Hodgkin in 1832. And we saw the point that it spreads orderly from one group of lymph nodes to other. So you can stage the patient correctly, and you can give the correct prognosis for the patient. And one important thing for Hodgkin's lymphoma is you have to see these cells called as Reed-Steinberg cells. Okay, those are the malignant neoplastic cells of the Hodgkin's lymphoma. That is again a 3 marks question for you. Okay, and going to the etiology, some people are genetically predisposed to develop a Hodgkin's lymphoma, and Epstein-Barr virus is also implicated in the etiology of Hodgkin's lymphoma. So the introduction part, you can write all these things. Introduce the lesion, Then give 2-3 points about the lesion, etiology and the person who described it, and tell the classic point is your presence of Reed-Steinberg cells. Okay. Going to the clinical features, it has got a bimodal age distribution, which means that one peak is seen in young adults and other age peak is in the older individuals. Okay, and it presents as a painless enlargement of cervical lymph nodes, and the lymph nodes are firm and rubbery to touch. And some patients may have symptoms like fever, weight loss, and night sweats. And oral cavity involvement is very rare in a Hodgkin's lymphoma. Oral cavity involvement is more common in a non-Hodgkin's lymphoma. Okay, as I said, the Reed-Steinberg cell, that's an important short note for 3 marks question for you. So, Reed-Steinberg cell, first say that it is present in Hodgkin's lymphoma. Okay, it is a characteristic malignant cell of Hodgkin's lymphoma. Then describe the cell. How is the cell? It's a very large cell, 20 to 50 microns in diameter, and it's got an abundant cytoplasm. You call that as amphophilic cytoplasm, which means that it is blue-red in color. So it takes up both acid dyes and basic dyes. Okay, so it's an abundant large cytoplasm, large cell, and you have two nucleus, mirror image nucleus, and inside the nucleus you see prominent nucleoli. Okay, so I've given the picture in this. I've drawn a picture of that. So you have a large cell. Inside that you have two nucleus. Inside the two nucleus you have very prominent nucleolus, and this appearance is called as owl's eye appearance. Then you can also have a multinucleated Reed-Steinberg cells, and when that appearance, you have multiple nucleus inside the cell. In that appearance is called as pennies on a plate appearance. Okay, and you can also add 2 points like variants of RS cells. Reed-Steinberg cells can be found in different histological types of Hodgkin's lymphoma. That is, your lacunar variant can be found in a histological type called nodular sclerosis type, and you can see popcorn variants of popcorn cells of Reed-Steinberg cells in lymphocyte predominant Hodgkin's lymphoma. Okay, so that's your 3 marks question. So for the 3 marks question, write it is a cell of Hodgkin's lymphoma. It's a malignant cell of Hodgkin's lymphoma. Then describe the cell, big cell, large cell. Then you say two nucleus, owl's eye appearance. And if many nucleus are there, you can get a pennies on a plate appearance. You have variants of Reed-Steinberg cells in different types of lymphomas. That is a Hodgkin's lymphoma that you will see on the later slides also. Okay. So going to the histological types, you have the classic non-Hodgkin's lymphoma. Classic Hodgkin's lymphoma has 5 histological subtypes. Okay, that is a nodular sclerosis type, the lymphocyte-rich type, the lymphocyte predominant type, the mixed cellularity, and lymphocyte depleted type. Okay, so first type, the nodular sclerosis type. So why is it called nodular sclerosis? Because fibrous septa, which means that collagen fibers are septa, divides the cells into lobules or nodules. Okay, and the lacunar type of RS cells are seen in this kind of Hodgkin's lymphoma, which means that the RS cells lie in empty spaces or lacunae. Okay, you'd have heard osteocytic lacunae, osteoclast like in a lacunae. Okay, that means it's a space. Okay, so the lacunar type of RS cells are seen in nodular sclerosis histological type of Hodgkin's lymphoma. And the next thing is called as lymphocyte-rich type of Hodgkin's lymphoma. You can see the arrow mark points to the Reed-Steinberg cells. So you have Reed-Steinberg cells in a background of lymphocytes. All these blue dots in the background you see are the lymphocytes. The next subtype is called as lymphocyte predominant type. And you can see in the circle marked area, so that's called as the popcorn cell. Okay, so the nucleus of the Reed-Steinberg cell resembles the exploded kernel of a popcorn. So it is called as popcorn cells. That's a variant of Reed-Steinberg cells. The next thing is mixed cellularity type. So in this type, you can see the arrow marks pointing to the Reed-Steinberg cells. But the background is not only lymphocytes, you have a mixed inflammation. Okay, all the other inflammatory cells can also be present on the background. So it's called as mixed cellularity type, Reed-Steinberg cells plus mixed inflammatory infiltrate. The next type is called as a lymphocyte depleted type. So in the background, you don't have much of lymphocytes like your lymphocyte rich type and predominant type, but you have a very less of lymphocytes, okay? And you do have more of Reed-Steinberg cells. That is a lymphocyte depleted type of Hodgkin's lymphoma. So when you write in your answer paper, you don't have to draw diagrams for all these subtypes. You just mention the 5 types, and for each type you write one point. Okay, so nodular sclerosis, nodular pattern of proliferation, lymphocyte rich, RS cells in a background of rich of lymphocytes, lymphocyte predominant, popcorn cells are present, mixed cellularity, a mixed diffuse inflammatory with RS cells, that is Reed-Steinberg cells is present. Then in the lymphocyte depleted type, large number of RS cells with less number of lymphocytes is seen. So you just have to write it like this, okay? This much is enough. And draw one Reed-Steinberg cell, which you saw in the previous slide, with a background of blue dots. One picture is enough, okay? For the whole answer, one picture is enough. Then coming to the staging of lymphoma, Ann Arbor staging is used for both Hodgkin's and non-Hodgkin's lymphoma, okay? So this is a stage 1 patient, okay? So how is a stage? You can see the arrow pointing to one group of lymph nodes. So stage 1 is a single lymph node region is involved. And going to stage 2, you can see more than one node is involved or more than one lymph node region is involved. So 2 or more lymph node regions, but on the same side of the diaphragm. You can see that these are above the diaphragm. So 2 or more lymph node regions on the same side of the diaphragm. Stage 3, you have 2 or more lymph node regions above and below the diaphragm. Okay, you can see the lymph nodes both on the involvement on the both sides of the diaphragm. That is your stage 3. And stage 4 is a disseminated form of the disease. You have involvement of the lymph nodes, plus you have extranodal involvement like liver, spleen, and bone can also be involved. So when you write in your answer paper, write it like this. So Ann Arbor staging of lymphoma. Stage 1 is involvement of single lymph node region. Stage 2, 2 or more lymph node regions but on the same side of the diaphragm. Stage 3 is involvement of lymph node regions on both sides of the diaphragm. And stage 4 is a disseminated spread to extra lymphatic organs. And you also have designation as A and B. A means absence of systemic signs. We saw in the clinical feature, right? B is presence of fever, night sweats, and weight loss. And the treatment is chemotherapy and radiotherapy. So that completes your Hodgkin's lymphoma. It's a very important 5-mark question. Make sure you write about the Reed-Steinberg cell. Draw one diagram of the Reed-Steinberg cell and write about the histological types and staging of lymphoma, Hodgkin's lymphoma. The next lesion we see is called as Burkitt's lymphoma. Okay, it's also called as African jaw lymphoma. It is again a malignancy. Lymphoma is a malignancy, you know. So it's a malignancy of B lymphocytes. And it was first described by Dennis Parson Burkitt. He described it in African children. And the etiology is Epstein-Barr virus. And a translocation between chromosome 8 and 14 is seen in most of the Burkitt's lymphoma patients. And one more interesting fact is this Burkitt's lymphoma is more common in areas where malaria is more prevalent. Okay, because what they say is when the patient's cell-mediated immunity is lowered because of the malarial infection, and then later an EBV comes and infects your B lymphocytes, the patient will not be able to evoke an enough cellular response to counteract this infection with your EBV virus. So what happens? The EBV infects the B lymphocytes and they have an uncontrolled proliferation. So that point you should have to remember, it is more common in areas where malaria is prevalent. So cell-mediated immunity is basically lowered. So there is a more of a proliferation of these tumor cells. And you have 2 major forms. One is endemic or African form, and the other thing is non-endemic or sporadic form. In the endemic or African form, there is more of jaw involvement. Obviously, it involves the African children, and it presents as swelling of jaw bones, and they can also have loosening of teeth. And the non-endemic or sporadic form, you don't have much of jaw involvement, but you have involvement of abdominal organs. Okay, and it presents as abdominal tumors, and which results in swelling and pain. The patients can also have bowel obstruction. And this is an interesting fact or interesting point in Burkitt's lymphoma. So the histopathology is called as starry sky appearance. Why is it called starry sky? Because the background is very dark with the lymphocytes, dark staining lymphocytes, and you have pale staining macrophages scattered in the dark background. So it gives the appearance of a dark night sky with stars. Okay. So why is it called starry sky? You have a background of sheet of dark staining, blue, dark, you can see the lymphocytes, and inside that or in between that you can see pale staining macrophages. The macrophages are the stars, and the dark sky is your dark staining lymphocytes. Okay, so that's called a starry sky appearance. Underline that starry sky appearance. And treatment is chemotherapy. Usually Burkitt's lymphoma can be asked as a 3 marks question, very rarely as a 5 marks question. So tell that it is a malignancy of B lymphocytes, and tell the person who described it first, and write the 2 forms, and etiology is you can write about EBV, then you can write about the translocation 8 and 14, and you can also say that it is more in areas that is having more malarial infection. So all these points you can add. The next lesion is multiple myeloma, and the important 3 marks question asked in this is Bence-Jones proteins. Even it's an important viva question also. So what is multiple myeloma? It is a malignancy of plasma cells affecting the skeletal system, and so it's malignancy. Okay, and what cells are proliferating? Plasma cells. You know that plasma cells are the ultimate differentiation of B cells, and what do they produce? They produce antibodies or immunoglobulins in a normal scenario. So even these tumor cells, the malignant plasma cells, produce a lot of immunoglobulins. Only thing is they are a little abnormal. Okay, so the patients will have symptoms because of on one side it is because of the proliferation of these malignant tumor cells within the bone, that is malignant plasma cells within the bone. Then the other complications will be due to the product of these tumor cells, that is they produce lot of immunoglobulins which are not of any use. Okay, so that is again a complication for the patients, or that is again a problem for the patients. Okay, so what is the age? It is of older age group, above 60 years, and it involves the axial skeleton. So remember that it is present within the bone. It is a malignancy of plasma cells affecting the skeletal system within the bone. Okay, so what are the signs and symptoms of this disease? They're basically because of one thing is the proliferation of tumor cells within the bone, and the second thing is due to the uncontrolled production of protein products, because these plasma cells produce abnormal immunoglobulins in excess amount. Okay, so when they proliferate within the bone, they produce bone pain, fractures, anemia, infections, because they replace the normal marrow. Okay, and renal failure, because these too much of immunoglobulins, light chain products, become a burden to the kidneys. Okay, so the patients will have renal failure. And coming to the oral manifestations, the mandible bone, the jawbone can be involved more. The angle and the ramus area are more involved. And in radiograph, it presents as a radiolucent lesion. So any lesion which destroys the bone, it will present as a radiolucency. And the radiolucency in multiple myeloma is called as punched out radiolucency. Okay. And going to the lab findings, there is an altered albumin globulin ratio, because the globulins are more in this tumor. Immunoglobulins are produced more in the tumor. There is an increase in globulins. Okay, so albumin becomes less and globulin becomes more, and there is an increase in globulins in the serum, that is called as globulinemia. And another finding is called as Bence-Jones proteins. That's a very important 3 marks question for you. So what do you write for this Bence-Jones proteins? So it's a lab finding in the urine analysis of multiple myeloma patients. And patients have renal failure because there is an overburdening of excess of the circulating light chain proteins produced by the tumor cells. These are nothing but plasma cells. Only thing they are malignant. Okay, so they produce excess of these immunoglobulins. You know that immunoglobulins are made up of light chains and heavy chains. So you have excess of circulating light chain proteins produced by the tumor cells. And these light chain proteins in the urine of these patients is called as Bence-Jones proteins. Okay, so how do they present? This protein coagulates when the urine is heated to 40 to 60 degrees Celsius, disappears when the urine is boiled, and reappears on cooling. Okay, so this much lines you write for Bence-Jones proteins. Write that it is present in multiple myeloma patients. It is due to the too much of circulating light chain proteins, and these are called as Bence-Jones proteins. How do they present? They coagulate when the urine is heated to 40 to 60 degrees Celsius, disappear on boiling, and reappear on cooling. And this is the radiolucencies present in the skull. It is called as punched out radiolucencies. And treatment of multiple myeloma is chemotherapy. Okay. So Benz-Jones proteins is an important 3 marks question for you. And the next lesion we're going to see is osteosarcoma. So sarcoma means you know that it's a malignancy, and osteo means something related to your osteoblast. Okay. So it's a malignant neoplasm of mesenchymal cells which have the ability to produce osteoid or mature bone. So underline malignant neoplasm, underline mesenchymal cells which can produce bone, that is osteoid or mature bone. Okay. Then coming to the etiology, irradiated bone can develop osteosarcoma, and the Paget's bone can develop, it can be a complication of Paget's disease of bone. And some syndromes like Lieframani syndrome and Rothman-Thompson syndrome, those patients can also develop osteosarcoma. Osteosarcoma can be asked as an 3 marks question, or once the radiographic features of osteosarcoma has been asked separately as a 5 mark question. So going to the clinical types. So based on where this tumor is present, okay, on the bone, it is classified into 4 types, the clinical types. Okay. First one is periosteal, which means that you can see in the first picture, the pink thing is a tumor. It is present between the periosteum. That brown thin line is the periosteum, and the yellow line is the cortex of the bone, surface of the bone. Okay. So this lesion, the periosteal tumor, it is osteosarcoma, is present between the periosteum and the cortex of the bone. Okay. So what happens? You can see on both sides the periosteum is elevated. So you have elevated periosteum on both the sides, and in that space new bone will be formed. You can see a space is created because of the stripping of the periosteum. So that area will be replaced by normal new bone. Okay. That is called as elevated periosteum with new bone formation. And the second type is called as perosteal type, and that is the lesion arises as a mass from the surface of the cortex and is attached by a stalk to the cortex. Okay, there is no lifting of periosteum in this type. Okay, tumor is found as a mass attached to the cortex of the bone. Okay, and the third type is intramedullary type. That is, the tumor is found completely within the medulla of the bone, that is in the central part of the bone. Okay, that is intramedullary type. And extraosseous means it is present completely out of the bone, that is in the soft tissues. That is the fourth type. So just write it up. You just have to write the 4 types. Okay, periosteal type, perosteal type, intramedullary type, extraosseous type. Okay, periosteum means between the periosteum and the cortex. Perosteal is sitting on the cortex. Intramedullary is completely inside the central part of the bone, and extraosseous means completely outside of the bone, that is in the soft tissues. Going to the clinical features, usually young adults or young persons are involved, 10 to 25 years. That is a maximum growth period is seen at that time, and mostly affect the long bones of the extremities. But jaw bones can be involved with some frequency, and it's more common in the body of the mandible than the maxilla. A slight predilection is seen for the body of the mandible. And how does it present? Anything that proliferates within the bone, you'll have swelling and pain of the affected bone. Then if teeth is there, that can be replaced, or loosening of teeth can be there. Then it can create a facial deformity. If nerve involvement or it is impinges on a nerve, you can have paresthesia. So the arrow mark points to the tumor in the posterior part of the body of the mandible. Then coming to the radiographic features, I said radiographic features of osteosarcoma can be asked separately as a 5 marks question. Okay. So 4 radiographic features are there. 4 clinical types are there. 4 radiographic features are there. Okay. One is cumulus cloud densities. The first one is called as cumulus cloud densities. You can see in the posterior marked area, we have a mixed radiolucency and opacity. That is called as cumulus cloud densities. Something like fluffy clouds. Okay. Mixed radiolucency plus radio opacity. Next pattern is called as sun ray pattern. You can see in the first radiographic picture, you can see some white streaks that is coming from the surface of the bone, okay, radiating from the surface of the bone. These are nothing but new bone formation on the surface of the bone, which is affected by this osteosarcoma. So inside the bone, you have osteosarcoma present, the tumor is present. So whenever something is proliferating inside the bone, there may be a peripheral reaction of the bone, okay. So new bone is formed in a pattern that is perpendicular to the surface of the bone. New bone is called as, you call it as osteophytes. Okay. So some problem is happening inside the bone, The periphery of the bone produces new bone, okay, that is osteophytes. But in this osteosarcoma, it is in a perpendicular fashion. So it is called as like a sun ray, okay, it is called as sun ray pattern. And the next thing is called as widening. That next feature is called widening of periodontal ligament space, because the tumor cells encroach into the periodontal ligament space. So you can see in this molar, the periodontal ligament space is widened. So there is a symmetric widening of periodontal ligament space. And the last radiographic feature is Codman's triangle. So we saw in the periosteal type of osteosarcoma, that is, the tumor is between the periosteum and the cortex of the bone. So the arrow points to the area where the periosteum is lifted off or stripped off of the surface of the bone, and an angle or area is created. Okay, you can see the small brown lines. That is the area which is created because of the stripping of the or lifting up of the periosteum. That angle that is created between, you can see in this picture, that angle that is created between the lifted periosteum and the surface of the bone, that is a yellow line, and the lifted brown line, that is a periosteum and the surface of the cortex of the bone, is called as the Codman's triangle. That acute angle formed is called as the Codman's triangle. You can also see in this radiographic picture. So it's the area or the angle formed between the elevated periosteum and the surface of the bone. So when you write your radiographic features, just write it like this and underline these 4 features. Okay, one is cumulus cloud densities, write 1 point on that, mixed radiolucency and radiodensity, sun ray pattern, that is streaks of new bones radiate outwards in a perpendicular fashion. Okay, then widening of periodontal ligament, that is due to the infiltration of tumor cells into the periodontal ligament space. Codman's triangle, it is a space between or the angle between the elevated periosteum and the surface of the bone. Okay. Okay, then coming to the histology of osteosarcoma, just write it simply, okay? You don't have to write too much. Right, it's a proliferation of what cells will be proliferating, obviously osteoblasts, and they're not normal, they are atypical, they are malignant, okay? So proliferation of atypical osteoblasts with osteoid production. So there should be bone production, then only you can call it as an osteosarcoma. So proliferation of atypical osteoblasts with osteoid production. Underline atypical osteoblasts, underline osteoid production. And you can have basically 3 types based on histology: osteoblastic osteosarcoma, chondroblastic osteosarcoma, fibroblastic osteosarcoma. So these osteoblasts can produce either more bone, or they can produce more cartilage, or they can produce more collagen fibers. So whichever is more, you can give the name as that particular type: osteoblastic, chondroblastic, or fibroblastic. So the treatment for osteosarcoma is a combination of surgery and chemotherapy. So that finishes the osteosarcoma question. So it can be asked as a 3 marks question as such. You just have to reduce the points according to the marks. Okay. Then the radiographic features of osteosarcoma can be asked separately as a 5 marks question also. So for a 3 mark question, don't write everything. Okay. For a 3 mark question, introduce what osteosarcoma is. Maybe you can give the types and a little bit on the radiographic features. Don't write too much for a 3 marks question. Manage according to your time. So the next lesion is Ewing sarcoma. It's a malignant neoplasm of small undifferentiated round cells. That's a 3 marks question. Okay, Ewing sarcoma is a 3 marks question. You know, sarcoma means it's a malignant neoplasm. And what is a proliferating cell? Those are small undifferentiated round cells. Okay. And going to the etiology, there is a translocation between chromosomes 11 and 22. Okay, in the chromosome 11, you have a gene called as EWS gene, and the chromosome 22, you have a gene called FLI gene. Okay, so when these genes are translocated, you have a new fusion gene, which you know that every gene, what is a gene? It is a part of DNA which codes for a protein. So even this new fusion gene will produce a new protein that is called as CD99, which will be expressed in these tumors. So that can be used for the diagnosis of Ewing sarcoma. You don't have to bother too much about these things. You just have to prepare for a 3 marks question. Okay. So write etiology, translocation between chromosomes 11 and 22. That is EWS gene, if you remember the name. So just write the translocation 11 and 22. Okay. Going to the clinical features, it affects young children and young adults and children. It can also affect the oral cavity and presents as swelling of the jaw bones. So the radiographic feature is important in Ewing sarcoma. You know that it is a tumor of round cells, malignant tumor of round cells. Those round cells are proliferating within the bone. So that is a destructive lesion of bone. It is going to present as a radiolucency. So it's a destructive lesion of bone. But in the outside, as we saw in osteosarcoma, the periphery of the bone tries to produce some new bone. Okay, that new bone formation is not in a perpendicular fashion as you saw in osteosarcoma, but it's seen in a parallel fashion. So it's seen like layers of new bone is deposited like the layers on the onion. Okay, so it's called as onion peel appearance. Okay, so new bone formation is seen on the outer aspect of the bone as parallel layers. Okay, that is called as onion peel appearance. Going to the histology of Ewing sarcoma, you have sheets of round cells, right? You have sheets of round cells proliferating, and these cells are positive for CD99. So there's a study called immunohistochemistry or IHC, and if you do that study, these cells will be positive for a protein called as CD99, which you saw in the etiology also. Because of the translocation, a new fusion gene is produced and a new protein is produced that is called as CD99. So these cells will express the CD99, which can be picked up by a study called immunohistochemistry. You just have to write sheet of round cells and it is positive for CD99. And the treatment is surgery, radiation and chemotherapy. So that's for a 3 marks question. Okay. Then Kaposi sarcoma is again a 3 mark question. You know, sarcoma means it's a malignancy and it's what is proliferating vascular component. Okay, so it's a malignant neoplasm of vascular origin, and the etiology is human herpes virus 8 or HHV8. And you have 4 clinical types of Kaposi sarcoma. One is the classic or chronic form, which is present in the skin of the extremities, and other is endemic African form. And third thing is transplant or immunosuppression associated, which can be seen in transplant patients where the cellular immunity is lowered. And the last thing is AIDS associated. Again, the cellular immunity is lowered in these patients. So just write clinical types: classic form, endemic African form, and transplant associated and AIDS associated type. Then coming to the clinical features, you have 3 stages. Okay. The first one is called as patch stage. So you can see in this picture, you can see it's just a discoloration seen in that particular area of the palate. Okay, so which is marked in the arrow. So that is the patch stage, and slowly later on in the disease, the patch gets thickened to form a plaque. Okay, that is the plaque stage. And the last stage, it becomes nodular. Okay, it becomes a big mass that is called as the nodular stage. So clinical stages are patch stage, plaque stage, and nodular stage. And the oral cavity can be involved, and palate or gingiva are the most commonly involved sites. And it may become an exophytic mass at the later stage, like you see in the nodular stage, which can bleed very easily because it's a vascular lesion. Okay, and coming to histopathology, you just write there is a proliferation of spindle-shaped cells and blood vessels. Okay, because it's a vascular neoplasm. Just don't have to write in detail about the histopathology. It's only a 3 marks question. Write proliferation of spindle-shaped cells and blood vessels. And the treatment is chemotherapy and radiotherapy. And the next lesion is lymphangioma. Again, it's a 3 marks question. Once in Guhas, it was asked as histology of lymphangioma. Okay, so introduce 2-3 lines about lymphangioma and go to the histology. So it's a benign hamartomatous hyperplasia. More than a tumor, it is considered as a benign malformation, okay, of lymphatic vessels, where you have some abnormal proliferation of lymphatic vessels which don't connect to the lymphatic system. So that is called as lymphangioma. Okay, and the most common location is the lateral neck, and the lesion in that part is called as cystic hygroma. Okay, and intraorally also it can present, and tongue is the most common site. And the superficial lesions have a papillary surface, as you can see, and they can also cause enlargement of the tongue, that is called as macroglossia. Okay, so introduce, it's a benign hamartomatous hyperplasia, not a neoplasm. It is more of a just a vascular it's more of a malformation. Okay, so it's called as a benign hamartomatous hyperplasia of lymphatic vessels, and those lymphatic vessels don't connect to the normal lymphatic system, so they don't get drained out. Okay, so they get collected in that particular area. That is lymphangioma. Okay, and it can be on the neck, or it can be in the intraorally in the tongue also. And lymphangioma histopathology, you see dilated lymphatic vessels. You can see the epithelium on top, that's a arrow marked area, and below that area you can see collection of lymphatic vessels just beneath the epithelium. So the connective tissue papilla area is replaced in this lesion. So you have to draw this picture. Okay, histology of lymphangioma, that was a question, 3 marks question. So the next lesion is schwannoma, again 3-mark question. Histology of schwannoma was asked once in Kuha's paper. So what is schwannoma? Oma is a benign neoplasm. So schwannoma is a benign neoplasm, underline that, of Schwann cells. Schwann cells are the cells present in the peripheral nerves which produce the myelin sheath. So they are benign neoplasm of Schwann cells, and most common site is tongue. And histology was asked. Histologically, the tumor has 2 types of tissue. One is Antony type A and Antony type B. Antony type A, you have cells arranged in a palisading manner, which means that they are piled up on one another, palisading manner, around acellular eosinophilic zones called Verroque bodies. Verroque bodies can be again a 3-mark question. And Antony B areas are less cellular, less organized, and myxoid areas. Myxoid means they contain more of ground substance. Okay. So this is the picture of the histology of schwannoma. So the first is Antony A area, which is cellular, and the cells are arranged on one another in a palisading manner. You can see palisading means they are lined up like that picket fence appearance. So the cells are arranged in a palisading manner, and these cells enclose acellular areas, pink eosinophilic areas, and those areas are called Verroque bodies. Okay. And Antony B areas are less cellular, and they're not organized like the other Antony areas, and they contain myxoid background, that is the areas rich in ground substance. Okay, so just have to write it for 3 marks. Write the introduce schwannoma, write the histology, and draw the diagram. If possible, draw the diagram, or you can just write the points around for a 3 marks question. So with this, we finish this topic. So make sure you read all these questions. And as I said before, all the lesions present in the tabular column, prepare for a 3-mark question. And few questions like Hodgkin's lymphoma and osteosarcoma can be asked as a 5-mark question. Also read non-Hodgkin's lymphoma and syndromes like Stooge-Weber syndrome and Rendo-Osler-Weber syndrome. Okay. So I wish you all the very best for your exams. And may the Almighty God bless you and guide you through your exams. Thank you very much.
Thank you, ma'am. That was an informative session on mesenchymal tumors. Now I would like to invite Professor Dr. Deebu George Matthew, Professor and Head, Department of Oral and Maxillofacial Pathology, Annoor Dental College and Hospital, to give a brief overview about today's whole sessions. Sir, please.
Thank you, Dr. Jess, and thank you all the participants for actively being with us, like all through these sessions for all 3 of these Sundays. And today's session is very important because, like, most of the questions are being asked from these topics that we had discussed today, especially from the odontogenic cyst and the odontogenic tumors. Because odontogenic cyst itself, for usually 3 essays are commonly asked from odontogenic cyst. So most of the time, this, just like what Dr. Sunil had, explained, odontogenic cysts, usually when they first start with classification. So sometimes they can ask classify odontogenic cyst, or sometimes they can ask classify cyst of the jaws. So both ways they can ask. If they ask odontogenic cyst alone, you can just write about the developmental odontogenic cyst and the inflammatory odontogenic cyst. Or if they ask about cyst of the jaws, you have to mention about odontogenic cyst, you have to mention about non-odontogenic cyst, then you have to talk about the like pseudocyst. So all these three things has to be, if you can put them into a flow chart, like, and it will become much more easier for the evaluator to give you more marks. And the three common essay questions that has been asked from odontogenic cysts, because three essays is frequently asked from this particular chapter. That is classify odontogenic cysts and discuss in detail the clinical, radiological, and the histologic features of odontogenic keratocyst. Then you have to, sometimes they ask about dentigerous cyst and even periapical cyst. So these are the three common cysts that is being asked as essay questions. So remember, when you are writing about odontogenic keratocyst, there are a few points that you have to like especially underline. That is the high recurrence rate, the aggressive nature you have to underline. When it comes to radiological features, like we can put like Main's classification of the radiological features much better. You have to underline the scalloping. That is an important point when it comes to the odontogenic keratocyst. Then in the histology, you have to write the characteristic histological appearance of corrugated parakeratinization. You have to underline palisading basal layer cells. And you can even mention about the satellite cyst that you have to underline. We all know that there is a particular syndrome known as nevoid basal cell carcinoma syndrome, where you get multiple odontogenic keratocysts. So that if you can write a small note of that, that is going to make your answer more complete. And when it comes to dentigerous cyst, again, like, you know, another important point that you have to write is in radiology, there are three radiological appearances. And in the histology, when it comes, you have to discuss about the three potential complications of a dentigerous cyst. That is Unicystic Ameloblastoma, mucopolimoid carcinoma, and squamous cell carcinoma. So when it comes to the other cysts, like, you know, what they can ask is calcifying odontogenic cyst is another usual question that has been asked. And people have also asked about ghost cells, Rushton bodies, like, and nasopalatal duct cyst, dermoid cyst, brachial cyst, has all been asked for 3 marks questions and are been asked. And when it comes to odontogenic tumors, already we had a very large session about ameloblastomas, and the classification of the odontogenic tumors are very important. And ameloblastoma is the most commonly asked essay question from odontogenic tumors. All the other questions, adenomatoid odontogenic tumor, calcifying odontogenic tumor, calcifying epithelial odontogenic tumor, odontomas are all asked as 5-mark questions or as 3-mark questions. Like, you know, that is what usually been asked. When it comes to the mesenchymal tumors, even though you don't get essays from the mesenchymal tumors, you usually don't get essays, but there's actually a wide range of lesions that is there in mesenchymal tumors. It's very difficult to go through all of them. But what is interesting is, like, you know, usually they ask 5 marks questions, and 3 marks questions comes usually from this particular topic. That is a non-epithelial tumors, or what we call as a connective tissue tumors. This actually has to be called as mesenchymal tumors. So commonly what has been asked is schwannoma has been asked. Like osteosarcoma is one of the common questions that has been asked. It has been asked as a 5 marks question, and where you have to write about the 4 clinical types. You have to write about the 4 radiological appearances that you usually see. You have to write about the 3 histological appearances that you usually see. If you can satisfy all these things, like, you know, the osteosarcoma, like, you know, short essay, 5 marks questions will get over. So, and lymphangioma is another question that has been asked. Kaposi sarcoma has been asked. You have to also learn about Sturge-Weber syndrome. That is sometimes been asked as a 5 marks question. So these are all the things that has been discussed today. And I hope you have all taken like the maximum, you are taking maximum advantage of this program that we are conducting. And another announcement I have to make is, like, the next week's what do you call exam tips is been, that is on 26th September, exam tip is being postponed to the 3rd October one. So because, like, we want to give you an opportunity here, because we are conducting from Annoor Dental College, we are conducting international conference, online conference called Horizon Unlimited on 25th and 26th. And we don't want, like, you know, to take your opportunity here. So we are giving free registration from our college. We are giving a free opportunity for free registration for this conference. We will send you the links to the respective WhatsApp groups. You can register yourself and can attend this particular conference. And a lot of national and international acclaimed speakers are coming here. So in clinical dentistry is coming. So you get an opportunity to listen to their talks, and you see them and see all the things that has been discussed over there. So we don't want to take that opportunity out from you. So that is why we are postponing our next week's session to the 3rd of October, the first Sunday of the October. We are postponing it to that. And so thank you so much for being with us. So we will be posting shortly by tomorrow and day after tomorrow. We will be posting the details of this upcoming conference that you will be able to register freely and you can attend. Okay, so thank you so much.
Thank you, sir. We have come to the end of this week's session. Thank you so much to all the speakers of the day, Dr. Sunil sir, Anthony sir, Deebu sir, and Lakshmi Priya ma'am. Since we are organizing this international webinar titled Horizon Unlimited in association with online dentistry next week, the last module of Exam Tips 2021 will be scheduled to first Sunday of the month, October. So registrations are free. You all are welcome there too. Hope to see you all on the next module. Stay safe and healthy. It's me, Dr. Jis and Dr. Anjana signing off for the day. Thank you so much.